Good morning, everybody. Welcome to this workshop on research ethics during epidemics. Good morning, my name's Mags Thomason. I'm speaking to you from a quite cold, crisp London morning. And this workshop is brought to you by Pandora and Tessa, and also Alert and the Global Health Network. And we've got a very nice program for you today. I'm just going to run through one or two housekeeping things with everybody before we start. And I think we've got a slide up for that. Thank you very much, Bonnie. So just to remind everyone, so this workshop is being recorded and it will be shared on the Global Health platform. So you will be able to see this later on the Global Health platform on the various networks. So your participant videos and microphones have been disabled, so that's to enable nice smooth running of the workshop so we don't get interruptions. So in order to communicate, you can see on your taskbar you've got a Q&A box with two little speech bubbles, and that's where we'd like you to post your comments and questions. So for your questions to the panel for each of the sessions, please use the Q&A box. Please put questions there. The chat box, and I can see people are using that already, which is great, is where we can just introduce each other and say hello to everybody. So that's the difference between those. Chat box is for chat, Q&A is for questions and answers. Just a little reminder, if you would like to have a certificate for this workshop, to be eligible for a certificate of attendance, you do need to attend at least 80% of the workshop on both days, so today and tomorrow, and also to complete a workshop evaluation, and that will be shared in the chat box and it will be sent to you afterwards via email. It's only very short and it helps us to improve the quality of our workshops. And then you'll get that certificate automatically within about a month, so sometime early in the new year. Okay, well, I can see we've got almost 100 people online already, so that's great. So this morning we have two sessions. We'll be having a session on research in vulnerable populations and stakeholder engagement and community. And that's going to have 4 presentations and then a question and answer. Then we'll have a break at around 10:30 GMT for 15 minutes, and then our second session will be on informed consent in epidemics. So first of all, to welcome you to the programme, I'd like to introduce first of all Professor Sarah Edwards from Pandora, just to give us a note of welcome from Pandora. Sarah, please, over to you.
Thank you very much indeed. Yes, well, welcome everybody. Good morning. I'm very pleased to introduce the day from the perspective of Pandora. Pandora ID.net is a consortium funded by the EDCTP, so that's the European African Clinical Trials Partnership. It comprises a collection of 13 African and 9 European institutions, spearheaded by the Republic of Congo in Congo Brazzaville, led by Francine Tsumi. We're doing a fantastic amount of work. Looking back at some of the annual reports already, we've only been going since 2018, expected in the first instance to be going until 2022. But the fantastic amount of work surrounds capacity development, training, advocacy, and organised within 7 work packages. So I'm very pleased to be leading the research ethics and social sciences, plural, social sciences aspects of Pandora under the remit of work package 7. and that's led by Chatham House. So having fantastic support from them too. Without going into any minutiae about work packages, because that wouldn't set the day off very nicely at all, I'm just really pleased to say that we're fully immersed in COVID-related activities, from sort of evaluating and validating diagnostics through to analysing media reporting and doing surveys of healthcare workers in various places across Africa. Of course, we're not just devoted to COVID. There are many other really challenging emerging and re-emerging infectious diseases. So at the same time, we're also immersed in work on Ebola, Lassa fever, Zika, monkeypox, and Rift Valley fever, to name but a few. So I won't linger on any of those details now, because we've got such an exciting lineup, and I'm very, very thankful indeed for such an excellent program and schedule. It's looking all very professional and interesting, and I'm very much looking forward to it myself. So thank you, Blessing and Mags, and everybody else who's been involved.
Thank you very much, Sarah. Thank you for that welcome from Pandora. And Dr. Eusebio Macete from Mozambique, would you like to welcome everybody on behalf of Tessa, please? Yes, indeed. Thank you very much, Mike. First of all, let me congratulate Pandora and Alert for this effort, and this is wonderful. Not because we are part of it, but it comes in the right moment. As you know, the preparedness for the different diseases, for those diseases that we already know and we're familiar, and also for the diseases that are completely surprising the entire world. So the coronavirus pandemic has already, it's still showing us that we need to jointly being together in preparedness, in the implementation and designing policies. So those days, at different level, at national level, regional level, and global level, most of us were heavily requested to give our contribution to the world. And one of those areas is in ethics. Most of us, we know that we've been working for many years, from the last probably 2 decades, investing in ethics, investing in the countries to have a reasonable performance of the national ethical committees, and some of the countries that already improve it. But this doesn't stop there. So it needs that it has to be integrated. Most of us as researchers, we need to know properly which way the ethical review boards are going, how much they're prepared to support us in emergencies, in a situation like the coronavirus. So it's really, what I want to say, it's really came in the right moment. So thank you and congratulations for that. And for the TESA side, just say that this is a wonderful opportunity. And I'm glad that many of our colleagues and member institutions are part of attending this course. I hope that this could not be just one additional file in our boxes, but also we hope that this could be translated and improving the way how we're doing things in our community and preserving our community for what should be done for the world. So thank you very much. My congratulations, especially to Mark and Bless. We have been working for many years together, and we're not traveling those days, and seeing you in these moments is really amazing. And also Sarah for pushing this and making this possible. This is really wonderful. So thank you very much. I hope that this will be a wonderful workshop and will take home very important message. Thank you. Thank you very much, Eusebio. And what you were just saying there about the networks as well, and forming networks so that it's not just that we've got a piece of paper in our folders is so important. And this workshop will be going online, as we said, and also we'll be putting up some links later on for you to join our our Pandora knowledge sharing hub on the Global Health Network, where we've got a lot of useful information already on our ethics tab, and where we can have discussion forums, so we can keep these networks going that we're forming today. So thank you, and I'd like now to hand over. Dr. Eusebio just mentioned blessing, so I'd like to hand over my sort of co-host for this workshop is Dr. Blessing Silagwana, who is currently in Harare in Zimbabwe, who's going to introduce our first chair for our first session. So over to you, Blessing.
Thank you, Max. Thank you for the really nice welcoming. So again, hello everyone, and welcome to our today's session on research ethics during epidemics. I'm hoping everyone is excited about this session, and we really have a packed 2-day workshop for you with very interesting talks from a variety of ethical topics of doing research in pandemics. And without further ado, I would like to jump straight into today's business and introduce our first chair for the first session, Professor Ames Dai, who is, she served as the founder and director of the Steve Biko Center for Bioethics at the University of Witwatersrand in South Africa. She's an acclaimed international, bioethics expert, and we're really honored to have her chairing our first session of the day. So without wasting much of your time, I'm going to invite Professor Ames Dai to introduce our panelists for the first session, and so we can get started with today's business. Over to you, Professor Ames.
Thank you. Thank you so much, Blessings, for the introduction. Good morning, colleagues. I want to congratulate the organizers of this conference for putting together such a pertinent activity this morning. My task is basically to chair the first session, introduce the speakers, but I'm going to say a few words before I get into that. And just to remind ourselves that similar to other countries around the world, in Africa, we're also in need of effective pandemic research. And currently in the context of COVID-19, it just reminds us how much more we need to get into the research agenda of the world. And especially now with the COVID-19 vaccine research that's abounding. And we need this research to save lives in Africa, to protect the health of our vulnerable people. And also, very importantly, what we forget is socioeconomics. We need the research so that we can protect the health of our people and maintain socioeconomic development. It's very well known as a fact, and UNESCO said it in its statement on COVID-19 already in March this year, that vulnerability increases during pandemics. And it may actually appear for the first time during a pandemic. Therefore, any research that's done needs to take into consideration the backgrounds of our communities and the inequities amongst our socially vulnerable and disadvantaged groups. So I think it's so appropriate that the session of the conference, actually the conference itself, is starting off with a presentation on vulnerability. And it's following this up with a strong community component. Meaningful community engagement is pivotal as well, because it allows for the promotion of legitimacy, trust, and ownership of decisions. And this will allow for researchers to maintain trust, and faced with difficult decisions on certain research projects at this time, they need to be trustworthy. So I'm really excited about this first session, not because I'm chairing it, but because it's been so well thought out. So congratulations once again to the organizers. So without further ado, I'd like to start off with introducing our first presenter this morning, Professor Godfrey Tangwa. In fact, I don't even think I need to introduce him. He's so well known to everyone, but just a short introduction. He's a senior fellow in governance and ethics at Nkafu Policy Institute. He is also a professor emeritus at the University of Yaoundé. He currently serves as the vice chairperson of the Cameroon Bioethics Initiative, which is CAMBIN, which he founded in 2005. He is also an advisory board member of the Global Emerging Pathogens Treatment Consortium. The title of Professor Tangwa's talk is Research Within the Multiple Vulnerabilities of African Populations. So over to you, Godfrey.
Thank you very much, James, Guy, for that introduction. The Steve Biko Center remains a global point of reference, and I'm very happy to meet you here online after quite a long time. So if my slides can be put on the screen now, I can start my presentation. So my topic is research within the multiple vulnerabilities of African populations. And the chair has already introduced me. There's only one slight correction that I would like to make because it's a mistake that almost everybody makes. I'm emeritus professor of the University of Yaoundé 1, because there's Yaoundé 2. Every time I correct it, everybody thinks the 1 is a mistake, and so they delete it. Next slide, please. So what do I understand by research? By research, I understand a systematic inquiry or investigation aimed at attaining generalizable knowledge. And clinical research is a subset of research. And by clinical research, I understand an investigation related to the medical clinic, usually aimed at generating data for statistically valid evaluation of treatments and cures. There is non-clinical research by which I would understand all other research, whether it be public surveillance studies, health-related or not, including environmental, plant, animal studies, social science studies, observational studies, and so on and so forth. Next, please. Now, research involving human beings occupies a very special category of research, and it has been the subject of much controversy, regulation, and legislation. But all research, no matter what category it falls under, is broadly governed by the same universally relevant and applicable ethical principles: non-maleficence, justice, beneficence, and autonomy, in my view, in that order of importance when it concerns particularly research involving human beings. Next, please. What is vulnerability? I define vulnerability as the susceptibility or liability to be harmed, exploited, deceived, cheated, wronged, or otherwise unfairly treated in any way. That is my layperson's definition of vulnerability. If you want a more sophisticated definition, I would refer you to CIOMS. You can go to the CIOMS guidelines, guideline 15 particularly, and read a more sophisticated description of vulnerability that is worthy of the experts that many of you are. Next slide, please. As we see that when we talk about vulnerability, African populations, they suffer under multiple vulnerabilities. They are vulnerable as members of economically disadvantaged groups within the global economy. They are vulnerable as members of medically disadvantaged groups in the modern healthcare delivery system. Furthermore, they are vulnerable as minors, as women, as physically or mentally handicapped persons, as prisoners, as orphans, as patients, as sex workers, etc., etc. All these groups are increasingly used as research subjects for the convenience of researchers. Next, please. In Africa, we can say that vulnerability also applies to researchers, to scientists, and to institutions, research institutions, because all these, they have a huge conflict of interest when they want to do research, because they don't have the resources for doing research. So whoever will provide the resources will call the tune. We can even say that in Africa, governments are vulnerable on account of their resource and cash poverty and the natural tendency to cling on to power. Because of that, they are vulnerable and they can be manipulated against their own people, if only it would help them to stay on in power. At the very base of all these vulnerabilities in Africa are the historical experiences of colonization, subjugation, enslavement, proselytization, and the heavy yoke of a foreign hegemony. All these vulnerabilities and the situations which generate them, they produce the cumulative effect of accepting their definition, if not defining themselves as inferior, unequal beings who do not count equally with other humans and who are dispensable in ways that others are not. Next, please. Now, medical research with human beings has been well defined by the Declaration of Helsinki. And Helsinki 20 states, medical research with a vulnerable group is only justified if, 1, the research is responsive to the health needs or priorities of this group, and 2, the research cannot be carried out in a non-vulnerable group. 3, in addition, this group should stand to benefit from the knowledge, practices, or interventions that result from the research. Similar sentiments are expressed in the CIOMS guidelines, and you can check guideline 2 and 15. Next, please. Now, regarding CIOMS 20, who determines the health needs and priorities to which ongoing researches in African countries are responsive to? The answer is blowing in the wind. Secondly, what benefits accrue to vulnerable groups in Africa from the knowledge, practices, and interventions resulting from research in Africa sponsored and funded by, let's say, for-profit organizations or individuals? An African researcher has suggested that Africa should set its own health research agenda. Is this being done? That's another question whose answer is blowing in the wind. Next slide, please. The CIOMS guidelines also talk very clearly about vulnerability. And it says, when vulnerable individuals or groups are considered for recruitment in research, researchers and research ethics committees must ensure that specific protections are in place to safeguard the rights and welfare of these individuals or groups in the conduct of the research. This, of course, is also expressed in Helsinki 19 and 20, as I have already pointed out. Now, the research ethics committees in Africa, let alone researchers, comply with this CIOMS guideline? Is the reality not rather that no consideration whatever is given for recruitment of vulnerable groups and individuals in research, because all research is carried out on highly vulnerable groups and individuals? Next slide, please. The current situation of medical research in Africa, we can describe it briefly and summarily in the following terms. We can observe that the majority of diseases and epidemics are occurring in Africa. And the devastating effects of these on health, on security, and on the social and economic fabric of life, they threaten the very existence of the continent. And many of the existing medicines and treatments, they are either unavailable or unaffordable to people in Africa. So there's a crying need to research for affordable medicines and treatments to the multiple health needs of Africans. Next, please. But the majority of medical research in sub-Saharan Africa, with the exception of the Republic of South Africa, the Republic of South Africa is a special case which we can treat on its own. If we mix it up with the rest of Africa, it will complexify our problematic in such a way that we may not be able to see clearly. But most of the research that goes on in other countries of Africa, we used to say south of the Sahara and north of the Limpopo, it is mostly conceived, sponsored, and funded by industrialized Western world. And to facilitate this research, these agencies and funders, in some instances, they colonize and proselytize African institutions, researchers, and governmental functionaries to preach their scientific dogmas and projects, and they do so with the fervor and enthusiasm of religious catechists. They have been bought over into this, and they have bought into it themselves. Admittedly, of course, this research, conceived, sponsored, and funded by outsiders, it can contribute to capacity building and infrastructure development, but it should first be recognized for what it really is. Next slide, please. Now, there's something called human challenge studies, which is now going on in many countries in Africa. And you can see the paper highlighted here from the journal Bioethics. The title of the paper is Informed Consent for Controlled Human Infection Studies in Low and Middle Income Countries, Ethical Challenges and Proposed Solutions. This paper by frontline experts, it makes a very strong case for including illiterates and uneducated persons in Africa in this type of research. That is to say, the deliberate infection of healthy individuals with pathogens. And the question I ask is this really ethics? Is this type of paper coming out of a concern with protecting research subjects in vulnerable conditions? This, I think, is ethicalization rather than ethics. And ethicalization is something that is very noticeable at the global level now, where frightful, awesome experts, they spend their time justifying ethically procedures that medical researchers would want to carry out. You just give them time and they would come out with arguments which show how ethical it would be to carry it out. Next slide, please. Now, where is medical research ethics in all of this? It seems to me that we are fully back to the pre-Nuremberg situation as far as medical experimentation on human beings is concerned. Let us remember what the Nazi medical researchers were condemned for in Nuremberg in 1947, and the Nuremberg Code was elaborated. What one would want to ask is, what has happened to the Hippocratic tradition in medicine? What has happened to the World Medical Association? I don't hear their voice in all this deliberate infection of healthy people with deadly pathogens. I would really like to hear a justification of the deliberate infection of a healthy human being with a dangerous pathogen from a member of the World Medical Association who has actually taken the Hippocratic Oath. Next slide, please. Now, if everyone is talking about COVID-19, you know, and what should Africa do? What are the priorities for Africa given the COVID-19 pandemic? And we are caught within many dilemmas here. You know, all attention seems to have been diverted to COVID-19. And an African frontline researcher, you know, Francine Toomey, whom everybody knows, he is very connected with PANDORA and Alert. She's asked the question in a very recent issue of Nature: what if the world had tackled, let's say, research into malaria with the energy which is now dedicated to COVID-19? I think that the answer to that question is blowing in the wind. And the same question can be asked for the other ailments which are really of concern in Africa: tuberculosis, respiratory tract infections, laser fever, and what have you. Next slide, please. Research participants in Africa do need to protect themselves as best they can. I mean, we used to state, and it's in all the international guidelines, that research participants need to be protected. But I think they need now to step up and protect themselves. Because first of all, allopathic medical research is fundamentally opportunistic and exploitative. And if we look at the catalog of historical atrocities, abuses, and scandals, we wouldn't be in any doubt about this. When we enjoy modern allopathic medicine, we should know that we are enjoying a medicine which was partly based on atrocities, abuses, and scandals. And that apart, it is ordinarily not easy to refrain from taking advantage of the weak, the needy, the poor, the ignorant, and the vulnerable, especially in a context where the philosophies of liberal capitalism, utilitarianism, and consequentialism hold sway. Biomedical research is first and foremost big business. And wherever big business, driven by the profit motive, driven by power, influence, and control are at play, ethics and fair play and justice are likely always to be swept under the carpet. Let us remember that in 1994, President Clinton publicly made an apology for the Tuskegee scandals. And in 2011, President Obama did the same for the Guatemala scandals. And I think that we may be looking forward to the next public apology to humanity if the researches that are going on in Africa now continue with the momentum, with the present momentum. Next slide, please. Now, regarding COVID-19 in particular, it is a pandemic that seems to have adapted and manifested itself differently in the different ecological niches of the world. So why has there been so much emphasis and obsession with finding a global vaccine to the neglect of finding a cure, treatment against COVID-19? If environmental factors, genetic configurations, and behavioral practices are important in the manifestation and impact of COVID-19, that would seem to be a reasonable argument against a one-size-fits-all vaccine against the virus. The WHO seems in fact, to have anticipated the evolution of things and issued advanced directives outlining criteria for ethical acceptability of human challenge studies. That's to say, deliberate infection of healthy individuals with viruses and pathogens for any candidate vaccine against COVID-19. And the question I ask is this still ethics calculated at protecting human subjects of medical research experimentations? Or is this rather ethicalization calculated as crucial expert support for vaccine developers? The answer is blowing in the wind. Next slide, please. Now, more than ever before, African researchers are trying to add their voice, to really look at their situation and be speaking on behalf of their people. And I can draw your attention again to a paper authored by myself and Changwi Cynthia Monong and published in Research Ethics recently. Next slide, please. Now, here is my layman's guess or hypothesis, if you like, regarding COVID-19. I avow that I have no expertise in any of the medical branches or science or medical sciences. But my guess is that I've been a careful observer. Some of the epidemics that our world has experienced in recent times and those we can be expecting in the future are the resultant consequence of the artificial culture, an aspect of our exosomatic evolution, which is epitomized in artificial intelligence and machine learning and teaching that the world has been enjoying as fruits of the Western industrial revolution. I think that this exosomatic evolution and artificiality, or based on artificiality, clearly seems to have reached their logical limits. And I believe that insisting on pushing them any further may likely push human life and well-being over an evolutionary precipice. I believe that reversing this trend seems to me more important than finding a vaccine, let alone assuring equitable access to it for any of the pandemics that we are likely to be seeing in future. Next slide, please. So COVID-19 seems to me to be an epidemic which is particularly lethal in artificially built up areas from where nature has been banished by modern technologies. Environments where artificial structures stand taller than the tallest trees, let alone other plants and myriad other living creatures, if at all they still exist, may not be as conducive to human life and flourishing as we tend unthinkingly to think. And this is connected to what we also call climate change and all that, preserving the environment, preserving biodiversity. I think that our health as human beings and the health of the world that we live in is connected to these processes. more than to thinking that we will always find a vaccine for any virus, any pathogen that comes up our way. Next slide, please. And I thank you very much for listening. Very, very. Over, please.
Thank you. Thank you so much, Godfrey. You know, I've always enjoyed listening to your insights. And I think that you have set the backdrop to the rest of the webinar so skillfully and so eloquently. And you've left us with so much to consider over the next 2 days as we move into the sessions. So many questions whose answers are still blowing in the wind. And hopefully over the next 2 days, the wind could start subsiding. So thank you, Godfrey. We now move into our next presentation, and this is the move into the community component of the session. And it gives me great pleasure to introduce Mr. Patrick Fairley, who is the president of the National Ebola Survivors Network of Liberia. He served as the social mobilization, communication and community engagement lead for the Partnership for Research on Ebola Vaccines and Infectious Diseases in Liberia. Acronym is PREVAIL. The title of his talk is Community Engagement with Vulnerable Populations During Health Emergency, Using the Partnership for Research on Ebola Vaccines and Infectious Diseases in Liberia, Vaccine Community Engagement as a Case Study. We look forward to hearing your insights. Patrick, over to you.
Thank you very much. Let me say good morning, good evening, good afternoon, wherever you are. And I hope I sent my slide 2 days ago, and sharing it with. Could you share from that end? I will be so grateful to you for doing that. Thank you very much. Thank you very much. I want to say thanks to the organizer of this workshop, for the invitation. I'm Patrick Fairley. Thank you for the introduction. And today we'll be presenting on community engagement with vulnerable populations. Doing a health emergency using the PREVAIL vaccine community engagement as a case study. Next slide, please. Well, we will know the importance to engage vulnerable populations in conducting research. How do you engage vulnerable populations? When do you engage them? What are the cultural challenges in conducting research to vulnerable populations? We'll look at lessons learned and then recommendations. Next slide, please. Well, as president of the Survivors Network back in 2015, Liberia did not know much. We did not know much about research at then. There were little research being done by our research institution, but not publicly well known. And so when Ebola struck us in 2014, 2015, many of our partners, international partners, started to arrive in Liberia, and then there were a lot of research done. I work with a research institution called PREVAIL. We are conducted from 2015 up to now. We have conducted up to 11 research. Right now, we are on the observational research on COVID-19. And so, like we said previously, that engaging participants of vulnerable populations is very much essential, very much important to research, especially in a country where research is not well known. especially in a country where, in terms of education, you have about 60% of the population that are not literate. And so to provide information to the rural communities in terms of research to who be participants, I mean, especially in terms of emergency during the Ebola outbreak, was something that was very much difficult. And so from what we experienced, it is important to engage vulnerable population. Why? We need to mobilize the community leaders. We need to mobilize the stakeholders, I mean, those vulnerable populations, go through their leadership structures and make sure to inform them, to educate them on why it is important to conduct research. And so we also need to build trust and sustainable partnership with the vulnerable population. As we are aware that during the Ebola time, there were a lot of issues surrounding people who came down with the Ebola virus in the ETU. I mean, in a time of emergency, how do you talk to a vulnerable population, a vulnerable group, like the Ebola survivors? I mean, like the community, for which they were even accusing the researcher that they are the ones that are continuing to bring the Ebola virus in the country. And so we decided as community engagement specialists to engage the community, to build trust, to collaborate. In terms of recruitment, you have to continue engaging the local communities for acceptance. And when the local community accepts what you are doing, you have the opportunity to have a base or ground to settle and then talk with the vulnerable population. Here, I will refer to the vulnerable population as the Ebola survivors and even those that were in the ETU seeking treatment. Next slide, please. And so how do we engage the vulnerable population during research? I mean, it varies from country to country according to our culture. Here in Liberia, if you want to engage the research community, you have to start first with hosting a workshop, calling all of the community leaders within the terrain or the territory or the area where you want to host you want to conduct the research. And so the community leaders, youth, women group, civil society organization, local government authorities, you first need to engage them and inform them on the protocol. How is it the protocol look like? What exactly will you be doing with the human subject? Why is it important to conduct the research? So you have to carry on the awareness first with the local authorities, with the community authorities first, meeting them in series of consultative meetings, and they will in turn provide their inputs to the protocol. I mean, if you do not engage them, they feel overlooked. I mean, the trust will not be there and the collaboration will not be there. So what we did, using the vaccine, the preview vaccine study as a case study in this presentation, we engaged the community leaders in an advocacy meeting. In our advocacy meeting, we have less than 35 persons within the advocacy forum, where we will provide information on the research we have to conduct, the protocol we have to use that have been approved by ROBs and the United States ROBs and even our own country. And so there was series of engagement done, and we listened, we learned from the community. Some suggestions and recommendations made by the community was also accepted, and then we took it as research. So even the media, and sometimes in Liberia, the media report different from what we were doing. And so sometimes you will hear on the radio, the print and electronic media, and that Ebola has no cure. And then we were studying vaccine. I mean, prevention vaccine, Ebola prevention vaccine. And so versus what the media was saying that Ebola has no cure. In fact, when you get Ebola, there will be a lot of things that will happen to you and you will die. And then we as researchers working with the government was also, aiding the government in propagating information and messages, to community members working with the government so that community members can take advantage of going to the Ebola treatment unit once they have been diagnosed positive, versus the media saying Ebola has no cure. How can we break that barrier? How can we, erase that message that have been preached by the, being given by the social media and electronic and print media? Is by engaging the community and informing the community exactly what it takes, and then bringing the media into one meeting and informing them exactly what we are doing. Next slide, please. And so this is one of our strategies that we use during the vaccine engagement. We have community social activists, community leaders. The engagement continue. We have a cluster ring vaccine that was done, and then in order to allow the community to have that trust so that you can carry on your research, we have to engage community women group around the vaccine site, the vaccination site, religious leaders, government, community health volunteers. Even at that, when the nurses and doctors who's supposed to be telling the research participants that the vaccine is free, it does not affect, but they themselves did not have the opportunity to know much about what we were doing. And so they were in turn telling their community members where they reside that in fact the vaccine have pieces of Ebola in it. And so we have to engage the health workers again in a separate meeting and inform them about the protocol, exactly what we were doing. So in terms of community engagement in kind of research, especially with vulnerable population, they sometimes, because they are not in a restful mind to make their own restful decisions, they have to engage their community, their leaders, to make sure that their leaders understand, because they are in constant communication while they are in treatment room with their people. So you have to engage the community at all levels. Next slide, please. And so this is one of our meetings that it is an advocacy meeting. With our structure in preview as SMC, that is social mobilization, community engagement, and communication, we have 4 pillars. We have the advocacy pillar, where when a protocol is designed and approved by RRBs, we gather community leaders where that research will be conducted. Those community leaders will be there. The vulnerable populations, we're going to engage them to make sure that they understand exactly what the protocol says and what we will be doing as researchers. And so by doing that, we had the opportunity to even meet the vulnerable population after meeting their leaders. Because if their leaders are aware of what we are doing, they will give us the opportunity to meet the people and inform them on exactly what the research is. So this is an advocacy meeting call where you have governors, you have mayors, hospital, you have nurses, you have international partners, where we explain on what we are to do in terms of our research. Next slide, please. Engagement continues. So after the advocacy meeting, what follows is the community engagement. Like I said previously, the advocacy meeting is just about 35 persons within that identical community where we had to conduct the research. Community leaders for opinion, recommendations, and suggestions. So right after meeting the community leaders, our next agenda is to meet the community themselves. And so the community will tell us exactly, along with their leader in a single meeting, in a general meeting, where their leaders will be sitting and the community themselves will be sitting. And then they give us their own recommendations. And then we provide information to our traditional leaders, village leaders, to tell us exactly what we're talking about the research. And so that is a community engagement, over 100 persons. That is the largest forum where we carry our trial nurses, we carry our consent nurse, our study educator, we provide education to the general population. Next slide, please. And so when do you engage vulnerable population? I mean, with the Ebola survivors situation coming from the ETU, as president of the survivors, there were a lot of issues, complications. You have survivors coming down with eye problem leading to blindness. You have Ebola survivors coming with internal pain. Some are developing medical complications that, I mean, even doctors and nurses do not have the rightful procedure in even caring or catering to them. And so hope is lost coming from the kind of Ebola treatment unit. All of your belongings were disposed by government officials, and government is not giving you the relevant, what they're supposed to give you, because when you came down with the virus, you lost all of your materials. And when you're coming back from the ETU and you survive as Ebola survivor, you weren't given whatsoever that's supposed to be given to you. I mean, so livelihood support. And so within that kind of condition, some sleeping in churches, some sleeping in mosques, some sleeping in open veranda, and then coming with a research with the mindset that these researchers are the one bringing the epidemic in our country. And so it was a challenge. And so to engage them from the beginning was what we learned. So in engaging vulnerable population, like in our case, as a research, it's important from the beginning of the protocol development. So there were meeting called within the 15 provinces, the 15 counties, the leadership structure, and we held a meeting, and then we provide them the updates, the information about the research. And then people from their leadership got to know that, I mean, research is important. We told them how polio vaccine were being researched. We told them about all of vaccines, prevention vaccines that were researched. Over the period of years, we told them about therapies that were researched. They went through all of the processes. And so they buy into it and provided their own recommendations. How do we engage their own people? So they also recommended that we should also engage the vulnerable populations after the research takes effect. When it gets in the middle, we should always try to engage them so that we cannot leave out any information, because it will leave room for doubt, and you do not engage them. They left incommunicado. They left. There's no information coming to them, so they assume that this is what going on, and it becomes very bad for we as researchers. So we also need to engage them in the beginning, in the middle, and at the end. We should make them partner to the research. That's how we succeeded in our vaccine research here in Liberia. And so we should also engage in quarterly, like I said, quarterly engagement from the beginning, like I said, especially on updates, because they see the research as an opportunity to restore their hope in terms of medical benefits. And while researchers were saying that from the ethical perspective, you cannot be doing research at the same time treating. And so we have a problem with that in Liberia during our research. And so it became an issue. We had to go back on the table to dialogue, and there were a lot of education provided, especially someone coming from the Ebola treatment unit, experiencing a lot of health complications, post-traumatic stress. And we do not have, as a researcher, to provide those treatment, but we were only doing research. So it became a problem. And so we will recommend in our recommendations that once you are doing research with a vulnerable population, you're engaging a vulnerable population, you should not just engage them for research purpose. You should also engage them so that they can have some benefits, the benefits that will help them to recuperate, the benefits that will help them to get hope in the society, to regain the status in the society. Like that, I mean, where researchers were saying is a form of inducement, they cannot do it, versus ethic, versus cultural. And so there were a lot of issues. Next slide, please. So what are the cultural challenges? Like I said, clinical research in Liberia is a new phenomenon. In 2014, 2015, like I said, nothing much was known about clinical research. Although we have our research institution here, we're doing a little much research, but it wasn't well known to us. And so Ebola came and it widened our own horizon in research. So what are those challenges we have in the research? Misconceptions of the word trial. Why is it research participants, vulnerable populations were saying, why do we use the word trial? So are they guinea pigs? Are they animals set aside that we can come and do research on? And so so they did not understand the word trial. And so we try in our own understanding to inform them that this research goes through 3 phases. And then we explain those phases to them, that this is the last phase, and they have been through series of testing. And so understanding the word trial was something from our own culture was a little bit challenging to us doing the research. Understanding preclinical and clinical, it was something challenging. Why is it? What's the difference between preclinical and clinical? Is also something that the vulnerable populations were also eager to learn about. And so there was stigmatization of study participants. I mean, at our various sites, we have 4 sites in 2 of our provinces. And so when Ebola survivors are going to those sites to enroll into the study, I mean, there are a lot of issues, even in our vaccine participants going to enroll into the study. I mean, the normal community population will say, well, those are Ebola vaccine patients, or those are Ebola patients. So it brought a kind of stigma to our own research. We had to take extra time in to go to the various community and make the community understand that volunteerism in research it helped the world a lot. Whatever decisions that will be made from here will help the world. And I will speak, our research today on the Ebola vaccines is being used in Congo with the World Health Organization to subside the Ebola crisis that were in Congo. And so we explain to them, and the community get to understand. So they also look at study vaccine versus routine vaccine. Those are all jargons and words within the protocol they wanted to understand. Social mobilization was an ethical standard. Our social mobilization requires us to build trust. How do you build trust in a community if you are going for a community meeting and then one of the community leaders that's supposed to host the meeting along with you, you see them on the highway, and then according to our own standard, they cannot ride with you. If they ride with you to go to the meeting, you're influencing them. And so that in our own culture wasn't right. But on the ethical standards, the researcher was saying, look, it's something that we need to follow. We don't need to provide water. In our culture here, when you host a meeting over 45 minutes or 20 minutes or 30 minutes of an hour, it is your responsibility to provide food and water. That is our culture in Liberia. But then the researcher was saying, no, you can't do it. If you do it, it's form of inducement. And so there were issues surrounding that. There were a lot of information spread around that. We have a series of meetings. And so in upcoming research, I think researchers should understand when you are doing research in a country, you should observe the cultural, cultural diversity. You should understand the culture of that particular country, what it takes, to engage a community from the community engagement perspective. You should also look at that and try to limit some of the ethical issues that you're talking about. And so we also have in our protocol vaccine associated with side effects. How do they understand minimal effects? Everyone taking vaccine, whether it's a measles vaccine, whether it's a tetanus vaccine, you have a little pain in your muscle, a little pain in your muscle, little pain in your muscle. So because of that, if you say minimum side effects, or you will have signs and symptoms during the Ebola time, people will start to ask you what we say over the period of time, that the vaccine has Ebola in it, pieces of Ebola in it. Those are signs and symptoms of the Ebola. And so we have to sit and tell them exactly what it takes. Every vaccine you take, it sometimes gives you fever, it sometimes gives you pain. And so those are the side effects we're talking about. Or like I said, clinical research on new phenomenon. Next slide, please. Next slide, please. Lessons learned. What are those lessons that we learned during the vaccines or during the Ebola or during our research? Like I said, we are on the observational COVID-19 research right now in Liberia, in our research institution. We are conducting over 11 research right now. And so what are the lessons learned in engaging our community? We realize that research cannot be achieved, research cannot be possible without engaging national leaders, engaging our House of Parliament, the Committee on Health and Research. We engage them. You should always engage them. You engage the religious community, because these participants that come to your research goes to the various religious areas to worship. And so you have to engage their leaders so that leaders can be aware on exactly what you're doing in your protocol. We learned that we should have stakeholders included in the participant to participate in our various workshop. Even the participant should also be a stakeholder within the research. Stakeholder in the research, that they should be on principal investigator meetings. They should be representing vulnerable populations so that they can be aware exactly where the research is heading, how far they have gone. And so they can take the message back. It's a form of building trust. And so what we learn also is to engage the clinical research, especially as a response efforts in any outbreak intervention. We should also work with the relevant authorities in an outbreak, making sure that providing proper information, that information cannot be misleading, and it will have a serious problem and negative impact on your research. We should also have respect for participants in clinical trials. We should build sustainable partnership, not just come and do research in Africa and leave. What's the trickle-down effect? What's the benefit for those research participants, although they are voluntary? What would they get in return? These are vulnerable populations coming from a kind of health emergency, coming from an Ebola treatment unit. They are traumatized. They need psychosocial counseling. They need livelihood. And all we care about is just to conduct our research and leave. And so what we learn is that we should also engage other partners that will come to the aid of these participants, not just to engage in clinical trials and leaving the vulnerable populations as it is. And then if we do that, the burden will remain on national government, and national government has so many priorities. And so if we do that, you won't build the trust again. No, you will return after conducting the first research. You always want to work with the community in conducting all the research. We have some cultural context impacts, ethical standard, like we said. Transparency enhances trust. Whatsoever you do, you should provide updates, and the updates will help to build the trust. And the research participants will always build that trust with you in working along with you. Early engagement minimizes suspicion and skepticism. Because if you want to conduct research, if you do not engage the research community, and then you go in the middle of the research, there will be suspicion, especially taking into consideration during the Ebola outbreak. There were a lot of suspicion that Ebola was manufactured by our international partner, or brought into the country by international partner. And then if you have these kind of suspicions and skepticism, and then you do not engage the community with what you're about to do as a researcher, into the community, engage, and just to take the full population, in the community proper, there will be serious consequences. And so we learned that you have to engage the participants at the time in the community. Next slide, please. Next slide, please.
Patrick, are you going to be very long, or is this your last slide?
Oh, I think internet connection. Hello, you getting me now?
Yeah, can you hear me? Are you going to be very long, or is this your last slide?
This is just the last slide in recommendation, and
because we're really running out of time. Yeah. Okay.
Yeah, that's the last slide coming. The last slide. Yeah. Okay. Recommendations. Yeah, these are recommendations. I mean, since it will be shared across after the workshop, I mean, you can look at it. These are our recommendations. So, researcher, when you're conducting research.
You could quickly go through your recommendations. Okay, it looks like we've lost Patrick. Patrick, are you there? You can quickly go through your recommendations, and then we'll move into the next talk.
Thank you very much for giving the opportunity. And these are my recommendations. I will be here for questions, just in case. And so I appreciate it. Thank you very much.
Thank you. Thank you so much, Patrick, for sharing those very valuable experiences and insights with us. And these are your experiences on the ground with communities. We move now to Mr. Jimmy Terli. It gives me great pleasure to introduce him as the next speaker. Jemmy serves as coordinator of the Institutional Review Board at the University of Liberia Pacifica Institute for Research and Evaluation. It's an HIV standard prevention, infectious diseases and social sciences research center in Liberia. The title of his talk is Social Mobilization and Community Engagement in an Epidemic Emergency, the Liberian Ebola Experience. I'm also going to appeal to our next two speakers to try to keep to time, because there's a number of very, I would think, valuable questions that have come up, and I think we need time to engage on the panel discussion. So over to you now, Jimmy.
Good morning, good afternoon, good evening from Monrovia, Liberia. Can you see my screen?
Yes, we can see your screen, but can you put it onto slideshow, please?
Okay. All right. So again, I'll be running you quickly through practical experiences during epidemic in Liberia, particularly Ebola, and what were some of the fundamental critical roles that social mobilization and communication play during the period. So what I'm saying here is my own practical experiences where so many research institutions going to the field, research sites, engaging members, attending meetings, engagements. And so these are my practical experiences. And that can be, okay. So, so as I was saying, so these are the outline for this presentation. We'll be running you through the pillars of social mobilization, community perception, challenges, lessons learned, and what have you. So there are 4 critical areas that should be considered when, conducting, whether it's clinical trials, whether it's social research, whether it's anthropological, but these are fundamental pillars that should be considered. And I can tell you from Patrick's presentation, this was a new phenomenon. I would say not just in Liberia, but across the West African region. And these are critical, concepts that were used and work well. So there has to be advocacy in the first place. You need to have people in communities that will advocate for the conduct of anything, not just health-related issues. Anything that you want to get community buy-in, there has to be an engagement. So in an aspect of the epidemic, there were apprehension, confusion around here, across the country, and people face the reality of sudden deaths of entire households, entire communities. I mean, Liberia had the highest rate of death concerning 3 countries, Guinea and Sierra Leone compared. And so there were confusion, trauma across every community. When you hear the siren going through the streets, you know that they're going to a better side. And so that in itself tells you that when researchers come in, that they want to conduct, or they want to help provide scientific help that the world will benefit from, but we want you to enroll in a study. Hey, I'm not going there, because there are a lot of myths. And so you need key advocates from communities, in fact, from political level. I can tell you for a fact, even at the parliament, all right, there were apprehension, because we haven't conducted clinical trials in Liberia at that magnitude with a disease or virus that absolutely have no cure. So you can imagine that from the presidency. So you needed advocates from within the research team to talk to the drop the fears of the politicians and drop the fears of the presidency. And communication was critical in that piece. Information that you're providing have to be accurate, have to be evidence-based, that even the marketeers in Liberia, marketeers are those that sell in the market, most of them haven't been to school. Again, these are people that are very critical. They listen to you, but you have to convince them that indeed that what you're saying is true. And so there have to be a lot of factors involved. There have to be meetings, campaigns, you have to use all of the social networks possible, even involving the media, have the journalists trained, let them know what health reporting is, because a lot of journalists, they just report, but they don't know what's the bedrock for reporting on, for example, clinical trials, okay? So that's a different area, and you need those people. You also need to monitor what's going on. Okay, it does have to be a partnership. There has to be collaboration, and so we have to. The researchers have to see. The communities need to see what's going on. There are very players here. The Ministry of Health, which is a fundamental pillar, needs to know what's going on, because the people believe in the Ministry of Health. Again, the perception in an epidemic leads to speak about COVID right now. So there are a lot of apprehensions about COVID. Okay. I won't want to say the good thing about it, but the amazing thing about it is that you see that the level of fear when it comes to COVID in here, and I would say that can be said about the rest of Africa. There is a dramatic decrease when it comes to the death toll. But when you look at the news of what's happening in the West, so I mean, it's like, is this real? Okay, so now it was Ebola affected, killed a lot of Africans, but today it's a reverse. It's COVID, but it's not killing a lot of Africans. Rather, it's killing places where you have the best scientific brains struggling to do the same thing. There are a lot of engagement going on. Allaying fears with all of the different political, different scientific divide and what have you. But so that perception have to be worked on by people that have clear scientific mind and are saying the truth as is being done in any epidemic. Some people here, you can't take blood from their skin. All right, traditionally you can't do that. Other traditions say, hey, I don't donate blood. Why do you want my blood? So there has to be high evidence from a social mobilization perspective and communication to allay the fears and not shunning the social norms and tradition of communities. With the Ebola vaccine here in Liberia, that worked even among Muslims. Okay, we also have the cognizance of the climate. All right, when there's rain in Liberia, malaria levels go up. During the dry, malaria levels drop. So again, it took a time to let the marketeers, to let the farmers know exactly how pandemic works, how diseases work. And I can tell you from the lot of engagement that happened, I mean, there were a lot of fruitful results that came up. So other major issues around this, as I said, I mean, I'll just be repeating, it's just what I'm saying, we have to be cognizant of low literacy rate. We have to be careful with stigma. There's a huge Ebola survivor population here in Liberia that Patrick's headed. Okay, there were a lot of apprehensions in the minds of the survivors because you have to enroll these people in prospective studies to look at the different health implications that they were going through when they survived Ebola, from the eye to the semen and to the breast milk, pregnancy, you can just name it. And I can tell you, with all of this engagement, this was a monumental effort that was led by big research organizations here in Liberia, through collaboration with big cultural associations, with the Ministry of Health. I mean, driving across the country to propagate the message, encourage people to come to get involved in clinical trial. And this could not about benefiting you directly, but benefiting Liberia and having a replicating effect in terms of the benefits that the rest of the world are going to benefit from. As Patrick alluded to, with the VSV vaccine that tested very efficacious, all right, across the region, that was used in DRC. So now you have a standby vaccine, that can be used for any Ebola outbreak anywhere in Africa or anywhere in the world. Okay, so these were informations that were given to communities, and even right now, communities are aware that indeed there's a vaccine that is ready to go, just in case that there's any flare of outbreak anywhere in Liberia or in the sub-region. So SMC have demonstrated substantial investment, all right, in community engagement and education. Again, as I said, there are challenges everywhere. Right now with COVID, there are political challenges, there are social, cultural challenges, but there's no challenge that is insurmountable, okay? And that can work with any pandemic, anywhere in the world. And I can tell you it's going to work with COVID, as right now it's being done by SMC, social mobilization, and other groups here in Liberia. And so that's fundamental. Stigmatization will continue to exist. And I can tell you for a fact, those that have come out from the COVID centers, I mean, mind you, COVID is not for poor or rich. You got rich people that right now are on a quarantine. All right, you have poor people that are on a quarantine. You have presidents, you have kings. So these are information that community from the very inception have to get to know about. And so we learned from practical experiences sitting on the ROB, working with researchers, working with different interest group, that it's important for community to own, to be an owner in terms of research. If you don't involve community, opinion leaders, you're going to fail. And I can tell you, if those strategies weren't used here, we wouldn't have had a successful, a successful enrollment in the several clinical trials that took place here during the Ebola outbreak. Involved the traditional leaders. These are people that may not have gone to school, but they're very wise. You sit with them. I mean, you drop your PhD and, want to be tutored by, the reservoir of information when it comes to human relationship. So regional collaboration is also fundamental. We learn a lot of lessons from Guinea, Sierra Leone, vice versa. And these also help in mitigating Ebola in the region. You have to be truthful, you have to be transparent, you have to be accountable. And these are fundamental things that the SMC in Liberia use. Social mobilization, communication, clinical trials, these are fundamental things. Because if you tell the community person here to the first impression, that's what we tell you. The way you appear, the way you speak, you take it as a face value. The next time you come back, you say, hey, no, this is not what you told us. So, talking to community people, you have to be very careful. Say the truth as it is. Anything otherwise is going to create a problem. And then building their own capacity, the local capacity is important. Researchers come, fly by night, collect data, they're gone. But that paradigm is changing. Okay, involve community people, create CAPs, community action boards to help, run research in communities. And so these are lessons that we learn from here, and these are building blocks. I can say for a fact that there are papers that have come up and that will be coming up on some of the best practices that came out of SMC activities, here in Liberia. And so we just want to say thank you all for your listening attention. And we stand by for any question that you may have today or anytime. Thank you so much. Over.
Thank you. Thank you so much, Jamie, for sharing your valuable insights and also your experiences and the lessons learned from Liberia, and also for keeping to time. Appreciate that. So it now gives me pleasure to introduce Dr. Kathy Slack, who is a clinical psychologist and head of the HIV Vaccines Ethics Work Group, known as HAVAC to most. This is at the University of KwaZulu-Natal, South Africa. Her interests are ethical concerns in clinical trials of HIV prevention modalities, and she's done a lot of work in community issues, including community or stakeholder engagement, informed consent, and adolescent enrollment. And the title of her talk is How Can We Strengthen Community and Stakeholder Engagement During the Ethics Review Process? I think this is really important because this is a very neglected aspect of the ethics review process. So Kathy, over to you. Thank you.
Thanks very much, Ames, and thank you very much to everybody for the opportunity. Can I just check, will somebody be advancing my slides for me?
Yes, yeah, I'm ready, Kathy.
Excellent, thank you so much. I may also switch off my video just to preserve my bandwidth, but I did just want to show my face at the beginning. Thanks again to the organizers for this opportunity. What I'm going to do is just describe some of the work that we're currently doing, and hope that it can feed into this broader conversation about research ethics in pandemic or emergency situations. The issue, the sort of big issue that we're focusing on is how the ethics review process, or RECs in particular, can strengthen community and stakeholder engagement in the field. So we are aware that there are many players that can impact engagement, but we're really trying to tease out what might be the particular levers that RECs could push or pull during this, during the to and fro that they have with investigators during the ethics review process. And obviously, I mean, you will all know this, community and stakeholder engagement is often positioned as a response to vulnerability, which Godfrey outlined for us in the first talk. So it's often positioned as a way of trying to offset the inequity in power between sponsor and investigator teams and community stakeholders, for example. So it really is one of the major strategies to try and offset vulnerability and prevent exploitation. Next slide, please. So a smaller question that we focused on is, what kind of engagement does ethics guidance value? Not necessarily ethical models or frameworks, and we know that you will all have your favorites there. This is just about ethics guidance. So we reviewed some leading international guidelines. It's obviously not many of the domestic guidelines that will may govern this activity in your own country, but really just some of the leading international guidelines, and 6 things came into focus for us. And they're there on the left, and I'll go through them with you. Because there's so many guidelines on the issue of community and stakeholder engagement, it can run literally to hundreds of pages of guidance. And sometimes that can be an impediment to seeing that certain things come into foreground. So we're just trying to foreground certain valuable recommendations from guidelines. And this goes to the critical question of, what does sound engagement look like? And could RECs recognize it when they see it? Could RECs recognize deficient engagement when they see it? And could they do that in a very way that's very grounded in guidance? So it's not necessarily in an arbitrary way, but it's really, really rooted in guidance. Next slide, please. So firstly, according to ethics guidance, and you can see them there on the left, good engagement is broad and inclusive. So, and I'd like to just draw your attention to the red circle. That is the WHO GPP, that's Good Participatory Practice Guidelines for emerging and re-emerging pathogens. And they argue that stakeholders, and they define it in a particular way, people who can influence or be influenced by a trial. So that is a very broad definition of stakeholder. And you've just heard examples from the previous 2 presentations about just how diverse that sort of spectrum of stakeholders can be. So you literally heard from Patrick and you heard from Jimmy the multiple stakeholders that they engaged at the local level through to national level, sometimes even beyond, so sort of multi-sectorial engagement at various levels, and very diverse interest groups, of course. And that's exactly the kind of engagement that is encouraged or envisaged in guidance. And what the GPP emerging pathogens guidelines seem to be discouraging would be engagement that is too community stakeholder focused and even CAB centric, and really wanting people to think beyond those stakeholders, and very critically in this situation, not neglect the epidemic or disaster response team, or that response body that is coordinating things at a national level. Next slide, please. So I just want to say one thing about the GPP EP guidance before I move on to this early and sustained. Those of you that have read it will know that it actually was written with pathogens like Ebola and MERS and SARS and Zika in mind. So it's really developed for situations where there are few medical interventions, things are urgent, there's a lot of uncertainty and gaps in knowledge, anxiety is high, suspicion is high, disruption is common, and resources are under strain. So that's really the sort of picture, the background triggering conditions that GPP EP have in mind. And they argue that despite all of those things, good engagement is early and sustained. And we really, you can read and read what they argue, but I think it's better to go back to some of the words of Patrick and Jimmy, where they were arguing for engagement at the beginning. And also Patrick said quarterly. So in other words, throughout studies, even when not much is happening. And what you really want to avoid is where there's a blitz on engagement at recruitment, and then it fades out or sort of weakens over time. So there's sort of a fade. And what you really want is sort of ongoing engagement. And I think that that was really made very, very clear by our two previous speakers. Next slide, please. Good engagement, according to guidance, has a responsiveness to context to it, and also a dynamism over time. And again, if you look down at the bottom, what these guidelines seem to be encouraging is really where investigators and funders don't do a kind of static engagement or allow their engagement to get stale, that all the time they're trying to keep it fresh and they're trying to respond to developments in the field, and that it really needs a nimbleness and a responsiveness. And I think we heard a lot in the previous two examples. For example, Jemmy mentioned adaptive. And that's exactly the kind of engagement that is really sort of valued in guidance. Next slide, please. The GPP-EP guidelines really encourage that guidance is informed by some sort of formative evaluation. Sometimes they use the word formative research. It doesn't have to be as formal as that, and undergo an ethics review separately. Sometimes it can just be an evaluation process, but this is really trying to make sure that engagement is based on, is responsive to the setting, the study, and really discouraging a kind of one-size-fits-all transplant, where you just transplant one engagement plan from one setting into the other. Next slide, please. The guidance also values engagement that is planned in writing, and this probably is trying to service a transparency goal and an accountability goal. But really, you'll see at the bottom there that the GPP-EP really want a transparent description of the planned approach. So they want some sort of description of the strategies and the methods. And I think we heard from the previous two speakers a remarkable array of methods, strategies, interventions, everything from meetings to quite innovative strategies. So in other words, a whole toolbox that could be described and thought about very, very carefully. Next slide, please. Guidance also values engagement that is resourced. So if you look at the bottom, GPP-EP wants adequate human resources, it wants sufficient funds. So it's really trying to discourage the tendency to under-resource engagement, or to cut engagement when times are hard. And often in these settings, times are very hard. You know, speed is of the essence. There's a lot of urgency, but it's really trying to make sure that engagement doesn't get the short shrift. And we heard actually about some of the substantial investments that were mentioned by Jimmy. You certainly don't do the kind of work that they talk about on nothing. And it's about trying to make sure that's planned. So next slide, please. A second question that we think is really important is it right for ethics committees to review engagement? And that might sound like a silly question, but sometimes one does have to respond to allegations of ethics creep, or sometimes you have to acknowledge that ethics committees take on an enormous review burden already. They are concerned with lots of problems, not just stakeholder engagement. But the answer to this question is a resounding yes. So if you were reviewing a trial of an emerging pathogen as an ethics reviewer, it would be within your core business to turn your attention to engagement. Next slide, please. That's some of the normative framework, but it's worth looking at some of the empirical research. In other words, to what extent does this happen in practice? So we have some emerging evidence from a review of REC minutes, or several reviews of REC minutes, and the person leading that research is actually on the call with us, blessing Saleh-Guana. If you look at the red section, this suggests that if you look at the review of minutes, that issues of community and stakeholder engagement more broadly are inquired about, but perhaps not as much as they should be. There is a caution in interpreting this research. So, for example, somebody could argue perhaps ethics reviewers are not raising this issue because it's managed so well already. In other words, it's sort of perfect, so there's no need to comment on it. But I don't think that that is likely to be the explanation. And I want you to bear in mind that this data is not about trials of emerging pathogens, but it is about trials that were reviewed by full committee, research that was considered non-expedited, more than minimal risk, reviewed by the full committee, and definitely would include clinical trials. Next slide, please. We've done our own review just domestically in the South African situation. So we did a review of 37 RECs that had their documents publicly available on their websites. And we really looked at them very, very carefully to see how well the form, in other words, not people, but just the materials, how well they might prompt researchers to plan engagement that is envisaged by guidance. We found many missed opportunities. I mean, some excellent things that could almost be best practices, but really a lot of missed opportunities. Next slide, please. So just by way of recommendations, we are of the view that the ethics review process represents a kind of unique opportunity to impact engagement. And we would really encourage REC reviewers to turn their attention to engagement. Obviously, there will be many competing ethical issues, and we're not naive about that. There will be a lot that you will be concerned about, but really to just try and keep engagement on your screen. And then the last two bullets, it's been drawn to our attention, and especially in the emergency context, you want engagement that is very nimble, that is very responsive, that is very timely, and can adapt to developments. So you want to make sure that ethics review doesn't interfere with that quality of good engagement. And we would also suggest that there's some flexibility, that reviewers should really be a bit flexible at this point about which documents should contain the plans and which documents should contain statements about financing or budgets, and also about the level of detail required. There certainly is a room for that kind of flexibility. Next slide, please. So we've been part of a group that has tried to develop a free online certificate generating course, and to try and sensitize RECs and researchers to really take this issue of community and stakeholder engagement quite seriously during the review process, and how they can better impact on that during the review process. And we're particularly interested in trying to reach out to REC members that comprise the community member, sometimes called the non-professional member, or the non-institutional member, or non-affiliated, or lay reviewer, because we think this could really provide quite a lot of empowering material to help them in those positions. Next slide, please. Just like to thank the partners in CASPA and USA who are really funding our efforts to try and strengthen community engagement and stakeholder engagement more broadly in the African continent. Thanks so much for your time and attention.
Thank you so much, Kathy. An excellent presentation as usual. We now move into our question and answer session. Without doubt, it's very clear that we need research in Africa. I mean, we have vulnerabilities, and we need to work around our vulnerabilities as well, but we need relevant research that's directed to our African needs. And what I've seen coming through as well is this recurrent reference to, from most of our presenters, is that's transparency and trust. What I'm going to do is we're going to get into the panel discussion straight away now. We will finish at 10:40 because we've run over time, and I hope you all agree to stay with us until then. It's a bit of an eat up into your break, but I'm sure that would be fine. I'm going to go to the directed questions and then to the general ones. So there's a question that's been directed specifically to Professor Godfrey Tangwa. Okay, my next request is, can the panelists please switch on their videos? And not to forget to unmute when they're responding. If you're having a problem with bandwidth, then it's understandable. But Godfrey, I hope you're still on. Dr. Cham asks, some of the parameters presented in profiling vulnerable populations in Africa are not too dissimilar to those related to disadvantaged populations in all settings. In this context, what strategies need to be instituted to ensure that indeed vulnerabilities are effectively addressed by research ethics committees and the global community? Godfrey, are you on?
Yes, I'm on.
Please go ahead. Over.
Should I respond to that? Yeah, I think that it is true.
While waiting for Godfrey to get back, I think to our other panelists, it's been mentioned that Africa must have its own research agenda. Who's really responsible for setting the agenda? And what time frame can we propose? I'll leave this to the panelists to come through. And Helena, from the Global Health Network, would you like to answer this as well? But let's hear first from our panelists. Jamie?
Yeah, okay. Yeah, so when it comes to setting the research agenda, I think this is a national issue. What we have observed here in Liberia is that the national government, through the Ministry of Health, do have a national research agenda. And this is intended to, one, have a strategic direction in terms of, what direction and what are the critical issues that needs to be addressed when it comes to conducting trials during health emergency. And so this involves stakeholders, because the national government depends on scientists, ethicists and other players within the health environment to help them set up the research agenda. So the research agenda is not just set up by anyone, no matter what level of work you have as a scientist or as a research institution. You have to fall in to the scope of the national agenda that a country has carved out. Sometimes it's a 5 years plan, sometimes it's 10 years. So once those agenda have been set, then all the major players that wanting to get involved in what kind of work they want to do, it has to be in line with what the national government, have authorized. So setting the national agenda will involve a lot of players, but to be led by the national government through the Ministry of Health.
Thanks, thank you. So it's got to be the national government. How do communities come in terms of setting this national agenda? Patrick, any thoughts on that?
Yeah, so what is true that research is funded by government in terms of working in line with government relevant authorities, land ministries to carve national agenda. But we should also look at the research community and the community where the research is conducted. In order to have a national agenda and have a support base, I think many African governments across the African countries, their priorities is not really driven to research in their own domain. And so what I think that this agenda can be, settled by researcher. Researcher whole series of seminars, series of workshops, and come up, upgrade, because every country has their own agenda, but we have to come together as Africa to have a one straight agenda that is community driven, that is research driven, and every part of the society should be involved. The community themselves, the researcher, and the national government. Because how can we persuade the national government to support? Because there are a lot of priority areas. Liberia is no exception. National government priorities is on road, is on developing the economy and whatever. But in terms of supporting the research arm here, is little much known in terms of support. So as a researcher, we need to improve on our agendas, be persuasive, and work along with the community, and so we can have the agenda be put forth to national government. But we just leave it with government. For me, we won't get what we want to get. So the community need to be involved, the researcher need to be involved, and the government need to be involved. That's why every institution, every government have their own research agenda. But are they supporting it? The answer is no. There's no much support. That's just why you see foreign institutions are coming in and controlling our own research activities. And because of that, we do not have much say. And those foreign institutions are the ones having the much to say, because they are spending their own finances. And so we need to have the community involved.
Thank you, Patrick. Kathy, do you have anything to add to that? Over, Kathy.
Yes, just to say that, just to sort of try and see it from the perspective of research ethics committees, they probably won't set the national priorities, but they might be cognizant of national priorities and take those into account when reviewing protocols, especially for social value. I just wanted to make that brief comment.
Great, thanks. So I'm not too sure if Godfrey's back.
Yes.
Yeah.
The connection went off. It's coming on. And yeah. So you should respond to the question you had that was raised at the very beginning.
Yeah. Okay. And then we'll come back to, okay, Godfrey, I think let's finish this agenda setting. And then we'll come back to you. So here we're looking at the setting, the research agenda at national levels. But what about Africa per se? We do have the African Union, and within the umbrella of the African Union, we have the Africa CDC. And I think it's time we started asking what role the Africa CDC would have in terms of setting an African agenda. It's actually been quite active during this during this pandemic period, and it has set some strategies in terms of vaccine access, etc. So it would be good to see the Africa CDC playing a role in setting an African agenda as well. One of our problems, I think, in Africa is we're too isolated as individual countries. And because we don't come together, we don't have that bargaining power for lots of things as one would have should we be functioning as a collective. Thanks. Godfrey, over to you.
Okay, connection will allow. It's been on and off, so I have just a disjointed knowledge of what you have been saying. But there are two things. The question that was asked at the beginning, and you are mentioning of the Africans, whether it could coordinate. Africa has been very active in the recent past. Okay, so first of all, I was remarking that vulnerabilities, of course, occur in every setting. And what is important for addressing vulnerabilities, no matter what setting occurs, is that we are in a setting which is free and democratic. You see, there are vulnerable groups, let's say in the United States or in the UK, but because that's a domain with a credible democratic system, ethics review committee are reasonably free. They are convincingly free in their actions. Things can work there very well. And therefore, that is what we need to have in Africa. That's why I go back always to the issue to decolonize and to have which are responsible. When you have something, an SU committee, it is right to defeat.
I think we've lost Godfrey again. What I'm going to do is hopefully Godfrey will get onto a stable line at some stage where he can engage with us. But I'm going to take this question from Deogracius Rossi. Participants' compensation can be misunderstood by the community members. And he asks, what is the message that can convince them to motivate potential participants to join the trial? And whoever wants to go first. Go ahead.
Okay. Hello.
Yes, go ahead.
Yeah. Okay, this is Jimmy.
Yeah.
All right. So, can I go ahead?
Yes, sure. Go ahead.
All right. So, compensation for participants is another very critical aspect to look at during health emergency in the conduct of research. There have been a lot of debates, publications on what do you use to evaluate compensation for research participants, particularly in, I would say, in sub-Saharan Africa, where people live on less than $1 a day. Now, a good example is with the Ebola during the emergency. And I can tell you for a fact, the ethics committees in Liberia had to, weigh the benefit against the risks in terms of the fatality of a virus that was being researched. And the millions that were being pumped into clinical research were not used as a yardstick to compensate participants. And so in that vein, it had to commensurate with the everyday living standard, And so that had to take into consideration, for example, the time that a participant going to take to go through the consent process, the time that participant going to take to travel from their places of residence to the research site, so those are considered as inconvenience. On a normal situation, you do the same thing. And so it was based on these kinds of everyday practices that people go through that compensation was measured. And so if a trial was around $10 million, that would mean that you're going to give a participant $500 for a visit. No. It has to commensurate with the everyday living. even though he or she is going, have consented, So the issue of communication was vital, because I can tell you, there were rumors that they're going to be paid, P-A-Y. When you say pay, it's like you're on salary. So every day you come for your follow-up, you get salary. So they had to be demystified that a clinical trial is not a place for employment. If you consent, it's like your everyday living, but you will be given transportation from your place to the research site. The time you're going to spend, you'll be given food to eat. So these were what were measured into compensation. Okay, so and the community got to understand, and I can tell you with the several thousands, over 6,000 participants, got to understand that participating in clinical trial didn't mean that it was an employment. And we had to give them practical examples of all the medicines that people take across the world. These are medicines from malaria to typhoid to polio. These were all tested in other people across the world. Liberia at the time, you weren't a part of these clinical trials, but other people in other places did it, and that's what we use today to heal our children and to heal you. So those kind of information really had to be hammered down to the poor marketeer or to the farmers, and they got to understand exactly that it wasn't about pay, but rather it was about providing you an income.
Thank you, Jamie. Patrick, do you have anything to add to this?
Well, I lost internet connection, so if I can get the question, well, I can.
Okay, so maybe we'll move on to the next question, and I can hear your internet is really, really unstable. But Patrick, maybe you could tackle the next question then, also from Deogracius. And he asks that the research documents translation into local languages is a challenge. And how is this monitored for accuracy of information provided? Are sponsors involved in this? And especially in the case of an emergency and short time of action needed during the pandemic period. And I'm sure, Patrick, you've got quite a bit of experience to share with us and insights to share with us, considering what happened during the Ebola period. Patrick, over to you.
Yeah, so if I got the question rightly, how do you translate research document for proper understanding of research participants? Is that what you mean?
I'm sure that's what he means. How, what are the challenges of translation into a language that participants understand, especially where there's the pressure of time during a pandemic or epidemic?
Yeah, so there were a lot of challenges in doing that, because we managed to succeed in doing it, but it took time. Like you said, in the period of emergency, where we wanted to complete the vaccine research during the period of the Ebola, at the same time wanting to translate the protocol, because the protocol is done from a scientific perspective with scientific jargon, scientific wordings. But as social mobilization, you need to translate the protocol into a simpler term or simpler language where the participants or the community dweller can understand. In the midst of the Ebola crisis, it was a little bit challenging to get people, people with expertise in translating into local vernacular. For us in Liberia, what we did, we had an institution that we were working with that provided the expertise in translating, transforming the information in the protocol into a local dialects. And so when that was done into our 15 local languages, I mean, it helped us a lot, but it took a little bit. It took a little bit of time. And so what we did, even as that, we set up a committee. I mean, with the Ministry of Health, the incident management team, the health promotion division at our ministry, the Ministry of Health of Liberia. We then look at our messages and develop a local content message from our cultural perspective that help us. And so as part, we were in emergency, but we had the opportunity to gather few civil society institutions, few partners with the Ministry of Health, NGOs, because we have a complete message development committee within the Ministry of Health in the Health Division and the Health Promotion Division. So we gathered them, and then we brought our message that we wanted to engage the community and we want to engage in the vaccine and the entire protocol. And then we all sat together and then we developed the message in a local context. And it was very simple. And when you have expertise around the table, so like time like this, what you do, you call all of the partners that are working with the Ministry of Health. I mean, in terms of developing messages into simpler things, call the local chiefs to translate the information into the local dialect. So that's what we did, and it helped us a lot in translating the information. And the participants got the direct information, exactly what we wanted them to get. And it was very easy for them to understand our research purpose.
Thanks, thanks, Patrick. Did you, how did you, there was that pressure to actually recruit. How did you all address the situation of manipulation of participants in terms of recruiting them? How, did you have any considerations in terms of this? Yes, there's a dreaded infection, and you needed to recruit. But how did you actually approach participants such that they weren't manipulated into recruitment and enrollment? Would you be able to assist us with that, please?
Well, in terms of manipulation, I don't know exactly what you were referring to, but what we did is that we managed to engage the participants through a structure. What we did here, we helped the participants in structuring their own structural leadership, for which I was serving as the president of that particular leadership. And so we then managed, to inform them on our various consenting processes, how we are doing our recruitment, how we participants will visit our sites, and our various participant study nurses, our study procedures. And so we managed to explain in detail to our participants through their structure. Because in terms of emergency, in terms of outbreak, you cannot gather everybody in a specific area in terms of providing information to them. And so what we did was we brought participants in by numbers, according to our site, where our site will be able to receive 5 participants on a daily basis. We experience social distancing, and then we explain to them in our informed consent nurses. We explain the local things in the local dialect, in the local context, local English, and that's how we manage to get more participants in terms of recruitment. But in terms of manipulation, for that context, I don't know, in research, when you say manipulation, it says in terms of influencing them to enroll into the research. No, what we did was to give them more information after we engaged into the community. We engaged them on the radio, pretty electronic media, and we invited them through their structural leadership by by numbers, 5 in numbers, and then we engage them at the site again. If it is consent, the informed consent noise, we will explain in details to them. Some participants will say, well, I won't be able to consent right now. I'm going back to team number 8 to look at all of these things, and then we'll go home. And someone will return the following week and come back. They have understood exactly what is in the consent form. So that's how we manage to get most of our participants being recruited. I hope that helped.
Thanks. Thank you so much, Patrick. Yeah, it is quite a complex situation. At a time like this, participants are really vulnerable. They're anxious. I can remember at the beginning of our lockdown, personally, there was so much COVID anxiety, and you know, that COVID anxiety may have also interfered with, and this is from personal experience, it could have interfered with, you know, the way I interpreted messages that had come through, etc. It's really, really complex. But I want to move on to Kathy now. Kathy, are you ready? There's a question by Dario Scaramuzi. So what he says is that the global response to COVID-19 may require a reallocation of research priorities. And he gives an example. Some stakeholders interested in lesser vaccine development have switched to COVID-19 vaccine development. And does this reprioritization of previous research priorities lead to new ethical issues? And if so, how do we actually go about unpacking the issues and addressing them? Kathy, over to you.
So, Ames, I would hope that other people will speak after me, because this is sort of a public health ethics question and not so much a research ethics question, but I'm going to give it a try. I think it has been quite disappointing to see some of the attention move away from some of the intractable epidemics that certainly face people in South Africa. We're still having 1,000 HIV infections a day. 80,000 people die a year from TB. These epidemics are not going away. I think civil society advocates and activists have got a really important role to play to try to make sure that we don't lose gains that we've made in dealing with these other epidemics. But it is an incredibly difficult issue, and we did see the focus move away from these other problems and get focused on COVID. I think we should resist that. I think there's a creeping back to an understanding that we need to not reverse some of these global gains. But I'd be very grateful if some of the other panel members would also weigh in. At the very end, I'd like to just come back and make some comments about the payment issue, if you don't mind, Ames. But let's stick with this question.
Sure. Don't you want to? Okay, we'll finish this and then I'll come back to you on the payment issue. Jemmy, do you have anything to say to this in terms of reprioritization? Jemmy? Yeah, okay.
Yes, reprioritization of what?
You see, you do have country level research priorities, but yes. What COVID-19 has shown us is that that one had to move away from those already determined research priorities because something else came in the way. And would this lead to new ethical issues, and how would you address these ethical issues?
Well, again, you know, these are uncertain times, and so there will definitely, things are not static. You know, as I speak to you, yes, there has to be a retweaking of the research agenda. That's just clear. There are a lot of ethical issues that evolve during every epidemic. So COVID comes with its own, or COVID comes with its own challenges. And so those unanswered issues have to be reconsidered, or have to be considered rather. So yes, so the research agenda, I mean, is a living document. All right, it's not cast in stone. And so that's why, like here in Liberia, you do have what we call the incident management system. Okay, this is an emergency system that is set up during every epidemic. However, the IMS consists of a lot of stakeholders, national and international, that come to provide guidance on what's there and what should be embedded due to the prevailing epidemic. So yes, I think from an ethical perspective, research agendas should not be cast in stone. They can be shifted, they can be retweaked depending on the epidemic that is at hand, like COVID. So yes. So I think that, I mean, it takes a lot of effort, because the disadvantage is that it is an emergency. So during emergency, sometimes people do things to appease, the current situation, and then later on to correct it. But I think because, thinking in advance is such a difficult thing, because you don't know the scope of what's going to come. All right. So it's always good to have what you already have existing. But mind you, be always prepared that there will always be epidemics. Whatever form of shape it takes, national government and stakeholders, including the communities, have to be involved in resetting, national priorities when it comes to the agenda for research. Over.
Thanks. Okay, thank you, Jamie. Godfrey, I see you back on. Would you have anything to add to this?
Well, okay. I think I've missed much of the discussion because my connection kept coming on and off. What I can underline is the importance of research ethics in Africa, especially for those who do research and for members of ethics review committees. I think that outside of the Republic of South Africa now, this capacity building has almost stopped. There was a time in the early 200s when this was going on very satisfactorily, especially here in Central Africa. But ever since, there has been no such. So that even people who are appointed to ethics review committees, they don't really have the expertise to do review. And what I was going to say is that it's very important for ethics review committees to be free in doing the work that they do, not to have constraints on them from the government or from funders or from sponsors of research. And even where that freedom is limited, they can, in fact, fight to have that freedom once they have been appointed. That is to say, not just go along with things which are subtly imposed on them, but to stick to the principles of their work as they do it. So yes, there is vulnerability in every setting, but what will help in fighting vulnerability is that there should be that freedom of action, and that overall there should be a democratic, a free, liberal and democratic setting for people to work on. So that is it. That way, people don't have to be told of what is in their interest. They know it. But if they are free to push what is in their interest, then that is very good. You see, we have the CDC in Addis Ababa there, but I think that there was no need for America to create centers for disease control and prevention in Africa. But once that has been done, maybe it can move ahead and really work in a way that will be in the interest of the people. But so far, I don't think that the sort of issues the CDC in Addis Ababa has been obsessed with really come from the grassroots, not what is of interest to people at the grassroots. If they try to tackle that, I think that they would have re-entered.
Thanks, Godfrey. I think we've lost Godfrey again, but he did make some very useful comments. I want to go back to Kathy on the compensation.
Okay. Yeah.
Godfrey, I've moved to Kathy now. So, Kathy, to add to the, your take on the compensation issue, just to bring in two more questions on that. How can the compensation of research participants be improved considering the sacrifices they make? Julius Moyera asks that. And then there is another one by Abdulif Jallo, who says that in community engagement, when you bring together community leaders or traditional leaders to sensitize them about a clinical trial, would giving them transport, refund, or sitting allowance be accepted ethically? Over to you, Kathy.
Thanks so much, Ames. So I just wanted to circle back to some of the earlier comments that were made by some of the other panelists and reiterate them. So, I mean, the issue of payment is such a complicated one that it needs multiple interventions. And the first and most important intervention is to use a model of payments that is justified in the ethics guidance. And I think that really cracks the problem sort of halfway open. So if you look at international guidance, they do endorse paying participants, even if you don't like that word, to offset their expenses and then also to compensate them for time. And some allow for inconvenience, but many allow for time. And like Demi said, that needs to be indexed, that time payment needs to be indexed to the local setting. So you wouldn't use, the wage labor amount in New York, it would be indexed to the setting. And that's really to make sure that it's modest, that people are not unduly attracted to the research. They would have opportunities in their community for similar kinds of work, if you like, that would pay similarly to the research payment. So that approach is trying to get at this issue of so-called undue inducement. Then I think, so you need to really have an approach that's justified, a payment approach. Run it past ethics committees, obviously, and then monitor myths in the community that emerge about payment, because there will be myths that you're not paying for time and inconvenience, you're paying for organs or you're paying for blood or other things. So you really got to just make sure that you monitor those. I think communities are asked to understand so many complicated concepts that they can be encouraged to understand models of payment. Then I think you've really got to clarify the risks during the consent process, because what people are often worried about with payment is that people are blinded to the risks because they're so attracted to the payment. So make sure that in the consent form and in the consent conversations that you fully canvass the issue of risks. And then it's really about training staff, that participants really must be exercising their own free choice and ready to be sensitive to cues of discomfort or reluctance. And really to sensitively explore people's motivations. And they're usually multiple motivations. So the empirical data shows that participants are usually multiply motivated. So there's altruism, there's access to improved care or services where that may be an issue, and there's payment. And people are complex, and we're all multiply motivated. So I think that we can't really expect research participants to not be. So I'll stop there. Sorry, it was quite a long answer.
Thanks, Kathy. Yes, it is quite complex, like you say. And I think compensation itself would need a whole session on its own. Redmi asks a question. How do you deal with problems of culture and beliefs? It's not specific to research ethics, but I think it's very context. It's very relevant. You know, when people view the vaccine to be wrong and not to be used. So how do we deal with those problems and culture of belief? And how could we build trust with the community to help them understand the importance of vaccine despite the cultural beliefs? Any takers for this? And especially Patrick and Jamie, who are so involved with communities. Patrick, go ahead.
All right, so I think this is a public health ethics question. So there were, there were a lot of cultural issues around Ebola. I'll put it that way. Some took it to be spiritual. Some took it to be a curse. So traditional leaders in Liberia will have what you call the National Traditional Council. So these are cultural organizations that comprises of all of the cultures that makes up Liberia. And so remember here, we do have other religious groups. We have Christians, we have Muslims. And so Ebola was such a disease or virus, still is, that, it's a very jealous, nasty virus. You don't touch. Once you touch, you come in contact, you get it. And your chances of survival is slim. And so that was a message that permeated across. But there were other religious groups that were still carrying out what we call barriers, because the government was the one that was involved in, taking the bodies from all of the health centers or places in communities where there were bodies. So you had the team, like the deaf team, put it that way, Ebola deaf team. They went into the communities to collect their bodies. But a particular interest was the Muslim population, that believe in the washing of bodies. So if someone died in the Muslim culture, they have to wash the body before burial. And this exacerbated the death among this segment of the population. Now, from a public health ethics perspective, it took a lot of effort to talk to the imams, to the Islamic leaders, to let them know that, hey, what's happening among your people is because you are beefing. We have evidence, and so there has to be evidence to provide to them.
Carry on.
Yeah, hello?
We hear you now.
So just to summarize, they have to take a lot of evidence and convincing religious leaders about the do's and the don'ts when it comes to how you handle it could be your husband, your wives, your children, the community, and how you handle them during epidemics, because epidemics are unknown and they lead to death. And so the religious leaders or the Muslim leaders were able to buy into this because they saw that it was really rich in health among them. And so it has to take a lot of health promotional approaches. Talk to community, give them the facts about a current epidemic, what is known about it, let them know, and what are the don'ts and the do's, so that it doesn't spread and it doesn't kill a lot of people. So you have to come down to the level of them. You don't have to show yourself differently. That's one thing. You have to, assume or subsume yourself as part of them. So you need to have someone from within the culture or a particular tribal group to be a part of the team, or that understand, the dynamics of that culture or the intricacies. You need to have the kind of people to work on health promotion, on a social mobilization when it comes to providing information that will cut between or among cultural divides in terms of how they live, and how you can bridge those divides and ensure that everyone within a particular culture or setting can adhere to national health guidelines. And that happened during Ebola. Thank you.
Thank you so much, Patrick. We've now come to the end of this session, and I want to thank our participants for being, for posting such lively discussion and questions on the QA. There's a number of questions on consent, and I'm sure all your questions will be answered in the next session by Professor Commentary Moodley, who's quite an expert on this. So park this for her for the next session. I want to thank our panelists for their excellent presentations and for their excellent responses during the panel discussion. We now move into a break, and I'm going to hand over to Mags for any housekeeping between the break and when you come back. Thank you so much, everyone. Mags, over to you.
Ames, thank you very much for wonderful chairing of a very interesting session, and thanks very much, everybody. And sorry, I think we could have carried on forever, but let's have our break now. So we're going to have a break for 15 minutes. Remember, please, to put any questions in the Q&A and any chat in the chat, and 15 minutes, and then we'll come back. Welcome back, everyone. Hope you had a good break. We're going to now go straight into, I'm just going to ask if Blessing could kindly introduce our next chair and the next session, please. Blessing.
Thank you, Max. Welcome back, everyone. So we will now proceed on to our next session, number 2, which is on informed consent during epidemics. And we will have Dr. Mary Kasule to chair that session for us. So I will introduce Dr. Mary Kasule in a moment, and then she'll hand over to you so that she can invite the panelists for the consent session. So Dr. Mary Kasule is a research ethicist with a PhD in a diploma in bioethics and a master's in public health. She is currently working as a co-PI in the Human Health and Hereditary H3 Africa project being led by the University of Cape Town and the IF-Genera network. So Mary Kasule is a really internationally renowned expert in research ethics, and she's currently based in Botswana. It's really an honor to invite you, Dr. Mary, to chair this session for us on informed consent. So without any further ado, I'll hand over to you, Mary, so you can proceed with the session number 2 for us. Thanks, Mary, over to you.
Thank you, Blessing, for that introduction. I would like to, it gives me great pleasure to introduce distinguished Professor Moodley Kimantri. Please note that she has just been promoted to distinguished professor, and that is the highest position one can get at Stellenbosch University. So we congratulate her on that great achievement. Of course, she has worked very hard in this area, and she deserves, all those promotions. Professor Moodley is a distinguished professor and the director of the Center for Medical Ethics and Law She's also WHO collaborating center in bioethics. She's in the Department of Medicine at Stellenbosch University, South Africa. Her talk is titled Challenges to Consent Processes for Research During the Epidemic. Welcome, Professor Modley, and we are looking forward to your, always, useful insights. Thank you.
Thank you very much, Mary. Thank you for the invitation to speak, and I'm going to quickly share my slides. Mary, you can just tell me if you can see them.
Yes, I can.
You can. Okay. So the topic of informed consent during epidemics, I think, is extremely interesting and contentious. I've already seen a number of questions that have been posted during the earlier part of this discussion. And I hope that I will be able to discuss some of those issues and possibly answer some of the questions. So I think much of the discussion that occurs around consent often occurs in the context of research ethics. And if we think back to the 18th century, a large amount of research that happened occurred on a trial and error basis, largely because there were general practitioners who were working in their practices, trying one drug after the other, not knowing which one would work. And this occurred in the days where there were no large randomized controlled clinical trials. If we think back to 1796, Edward Jenner was an excellent general practitioner with a curious mind who was desperate to find a solution to the smallpox outbreak. And at the time, he experimented with cowpox inoculates and inoculated a number of people in his home, on his farm, including his own son at some point. And in this picture, you can see him inoculating an 8-year-old boy with the cowpox inoculate. Now, back then, there were few options to test new interventions. And as we all know, smallpox is eradicated today throughout the world, largely as a result of the vaccine and the work of Edward Jenner. It is unsurprising that the Oxford University unit working on the current COVID pandemic is in the Jenner Institute, which is named after him. And so this is the historical background around how research was conducted in the 18th century. Very far removed from the Belmont report and the requirements laid down in this report in terms of respecting autonomy, but beneficence and non-maleficence was taken into account because the doctors working on the smallpox vaccine in the early days and the early types of research were constantly weighing risks and benefits. The risks of dying from smallpox were far greater than the risk of being inoculated with the cowpox inoculum at the time. So although there were no formal consent processes, everything was done in the best interests of getting the smallpox outbreak under control. And that was in the public interest. Now, in normal times, apart from the very stringent consent processes that we are all familiar with, we know that various regulatory bodies around the world make provision for a waiver of consent with deferred consent in very specific emergency healthcare settings. This includes patients who come into a hospital who may be having a seizure, who may be in shock, or who have severe traumatic brain injuries. There are other areas as well, gray areas, patients with respiratory distress, depression, acute myocardial infarction, where the patient on admission to the hospital is often not able to provide consent, yet at the same time needs urgent treatment. And so for such emergency type research, ethics committees do allow for deferred consent, especially if other members of the family are not available to provide consent, and the interventional treatment needs to be administered urgently to the patient. Now, when we look at the context of live patients and where waivers of consent with a deferred consent option may apply, we know that for emergency research, the patient must have an emergency diagnosis and must need immediate treatment. The patient at the same time, because of his or her illness, is also incapable of consenting. The healthcare team or the research team has attempted to get consent from legal representatives or family, and this has been unsuccessful. The study population must have the same disease as the intervention or the clinical trial is looking at. So in other words, we cannot take a disease or an emergency type trial to a population that does not have this specific disease. The consent to remain in the study must be sought from the legal representative as soon as possible. We also know that whatever investigational treatment is being tried out must be potentially beneficial, and that the patient has not objected in advance to participating in research. This is not always very clear because most people don't think about their future participation in research. What is important is that we have to look at the practical aspects of the research not being possible without deferred consent. If there are any risks of a new intervention, then these should be minimal compared to the standard treatment. And in the context of deferred consent, one requires Research Ethics Committee or IRB approval, just as you normally would with any other study. So when one plans in advance that a particular study needs to be done in an emergency context with deferred consent, then one makes a regular application to the Ethics Committee in advance to ensure that there is proper approval in place. Now, in addition to all those criteria that I already listed for deferred consent in emergencies, committees may also expect that there would be some level of community engagement, that sometimes participants may have advanced directives for research participation. This is not very common. And of course, they will also consider how long the patient is going to, or the participant is going to be enrolled in a study without consent, before the deferred consent can be done. So these are just some additional requirements that will differ from one community and one setting to the other. Now, so for most of my life as a clinical trial principal investigator and as a research ethics committee member and as a DSMB member, I often focused only on the consent process that I was familiar with during regular research, occasionally for emergency research. But it was only when I worked with the World Health Organization in 2011, 2012, when I was part of a SAGE working group on ethical considerations for vaccination during acute humanitarian emergencies, that I became more sensitive to the issues of consent in emergency situations. And it became quite clear that consent could not be the same during an emergency of major concern compared to regular pre-emergency times. For us, we can think of pre-COVID times and we can think of inter-pandemic times and how research normally occurs. But during emergencies, things are definitely different. And of course, now we've all had the experience of COVID and the experience for some of you of reviewing protocols during this time and how much the thinking had to change. And what is clear during an emergency, especially the pandemic that we've just experienced, is that we cannot continue to use the regular traditional research ethics approach that we are all trained in. We need to think beyond that approach to looking at public health ethics, because after all, we are dealing with a public health emergency. that is not affecting 1 or 2 people, that is not affecting 10 or 50 people, but that is affecting huge global populations around the world, where public interest needs to be important and communal good needs to be considered as having a considerable role to play in all our decision making. And I know many research ethics committees have really struggled with making this transition to the traditional research ethics approach to a public health ethics approach that was seriously needed during this pandemic. As a result, many research projects were not approved timeously. Many research projects were declined because of a misunderstanding of the ethical approach that ought to have been applied to these particular studies. So I'd like you to refer you to this important article that outlines the 7 principles for public health ethics. And I think it's really sad that so little public health ethics is taught in so-called ethics committee training workshops, in programs that teach research ethics, in curricula at universities where ethics is taught. And if there's anything that we need to learn from this pandemic, it's the importance of ensuring that public health ethics is taught in all curricula where ethics teaching is occurring. So I'm going to look at some of these public health ethics principles and refer to research where possible. Now, one of the important issues that people really struggle with is limiting autonomy. And I think we need to remember that personal privilege ends where public peril begins. So a right to autonomy and a right to individual autonomy is not something that can occur without exception all the time. There are definite indications for when the right to individual autonomy is going to be limited. And we've seen it during this pandemic. Limiting autonomy was required when it came to isolation, quarantine, mandatory wearing of masks like occurred in South Africa, lockdown. That and in and of itself was the most blatant example of how individual rights could be limited in the public interest. Now, the United Nations Social and Economic Council made provision for such limitation of human rights in its Syracuse principles several years ago. And when there is a limitation of rights, it must be based in law. In South Africa, we had the Disaster Management Act that was put into place as soon as the pandemic was called. Other countries have similar provisions. The objectives must be legitimate, as we know was the case with the pandemic. It must be strictly necessary to achieve. So the limitation on rights must be strictly necessary to achieve the objectives. And importantly, the least restrictive or intrusive means must be used. So even if we had to isolate people or quarantine people, we needed to ensure that excessive force was not used, that it was done in a humane manner. So when we limit individual rights, it's important that humaneness is always taken into account. And of course, whatever we do should be based in science. So whether this is clinical treatment or research, there must be a good scientific basis for why we are trying out a new intervention. Now, another important public health principle is efficiency. So this would apply in terms of how we allocate limited resources, such as ventilators. It's going to apply from next week, possibly, when the UK rolls out the Pfizer vaccine, in terms of how we allocate vaccines. And of course, it applies equally to research in terms of how efficiently we use limited research resources in a pandemic. And this is something for research ethics committees to really think about very clearly. When research occurs during a pandemic, there are limited staff members available to conduct the research. There are limited resources in terms of everything that we need to conduct the research, and there is limited time. I think that is absolutely critical. This is the most time-sensitive research that we would ever do as has occurred during this pandemic, because the research is not done for the simple reason of publishing another article or somebody getting a promotion in a university. This type of research is intended to inform the pandemic, informed treatment of patients sitting in the ICU, informed treatment of patients in COVID wards in hospitals. This research has got to have an impact on the pandemic as and while it is happening, not after the time. And I think that is really important to understand. Then, of course, proportionality as a public health principle is critical. As I said earlier, the least infringement possible. So if we're restricting rights, it must be a restriction that is proportional to the aim that we hope to achieve. Costs and utility must also be proportional, and regulatory requirements likewise must be proportional. So there is no way we can take the old guidelines that were developed long before COVID and try and apply everything in those guidelines to research that is occurring during COVID. We really needed to think outside the box when the pandemic occurred. Now, social justice considerations are really important as a public health principle, and I'm sure we're all aware of the many health inequities that occurred during this pandemic. There were many vulnerable populations in research, as migrants, etc. And of course, there was the need for interdependence and solidarity. So that social cohesion was really important. And this is the type of social cohesion that is necessary in our community engagement drives, so that people understand the importance and the need for the common good, so that people understand what public interest means, and that we cannot continue to claim individual rights in the context of a public health crisis or emergency. Now, very importantly, I think when we review protocols on ethics committees, we need to visualize what is happening out there. Sitting in a room with committee members, looking at a written protocol and simply reading the lines is not enough. We need to have a visual picture of what is going on out there to understand how we need to temper our regulations to fit in with what is practical in the hospitals, on the front line, in the COVID wards. And we need to think about the different types of COVID patients. For example, there were people mostly who were mildly affected. Those people were perfectly capable of giving consent and taking part in research affecting a mild phase of COVID research. Then we had another group of people who are more moderately ill. These people required oxygen, may have required hospitalization. They may or may not have expressed an interest in trial participation, but if it was at all possible to speak to these patients during that time while they were in a general COVID ward, then the discussion of possible future trials was important to have with them. It was important, but not possible in all settings as well, because some hospitals were extremely busy and overrun, even with moderately ill patients. We need to think about how blood and other tissue samples could be collected during COVID. And it is possible that a large number of samples collected during COVID needed to be stored with or without consent. Because if in a week or two, the researchers, the doctors the scientists needed to go back to these samples and look for something different or look for the answer to a new question, then those samples had to be available and used carefully and responsibly for research related to the pandemic. And all of this, of course, would have to be done in the public interest. Then we have to think about the more severely ill patients, those with respiratory distress. And as you know, when I started my talk, I spoke about emergency research pre-COVID. And pre-COVID respiratory distress is one of those factors that requires deferred consent or that qualifies for deferred consent. So again, during COVID, we had respiratory distress, people with poor oxygen saturation, and that impacts on capacity to consent. There were people on ventilators and people who were intubated who could not consent to anything. And there were legal representatives and family members who were at home, not allowed to visit the hospital. And often some of those family members were sick themselves with COVID. And so proxy consent was under threat. It was not even possible to get proxy consent during the worst parts of this pandemic. telephonic consent doesn't work at the best of times. Video consent doesn't work if people don't have access to Zoom, to Teams, to WhatsApp video. We know that many people in Africa have a cell phone, but do they all have smartphones? And do they all have access to Wi-Fi? And so how practical are our suggestions going to be if they cannot be implemented? And I really would like ethics committee members to visualize what was actually happening in the hospital during the first wave, during the second wave, when the pandemic was really at its worst. What about the healthcare teams? They were mostly in full PPE, making it very difficult for communication, making it difficult for people to operate a cell phone. So there were some ethics committees that wanted the consent processes recorded on cell phones. They wanted pictures taken of the consent forms with cell phones. And imagine the risk of contamination and the issues that research teams would face, even if they went into wards with clipboards. Clipboards were regarded as, bad for infection control. Cell phones, everything that ethics committees were asking people to do was really difficult and in some cases impossible to implement. So during COVID-19, ethics committees had to make an urgent paradigm shift in thinking. We all had to move from requesting 3 copies of written consent to, in some cases, a waiver of consent with or without deferred consent. And I think this is the paradigm shift that was critical. And this is the type of patient. So I'm not saying that a waiver of consent had to be granted for all research during COVID. I think there were very specific studies involving extremely ill patients, intubated like this lady is, on a ventilator, in ICU, without any family present and possibly not contactable, where consent, a complete consent waiver, was the only way in which this research could have been done. So having been part of, or having been consulted by a research team to do critical care research during the first wave of COVID in South Africa in an ICU, I did a thorough review of the literature and together with my co-authors, gave this question considerable thought. And we published a very comprehensive article in the South African Journal of Medicine, in which we argued for a waiver of consent for critical care research in ICU after death. So many of our research ethics guidelines were written for pre-COVID times and were written for patients who were alive. But how many of our research ethics guidelines were written for people who were deceased, who could not consent, who legally had no rights at that stage after death, who did have family, but whose family may not have been present or available. And when the doctors phoned to tell the families that the patient had died, that this was not the most appropriate time to also ask family for consent for research, especially if tissue samples were being taken and a long explanation would be necessary. That was not practical during that telephonic interaction with the family member. So the ethics committee involved suggested that there could be a waiver, but they wanted deferred proxy consent. And this could occur after the time, which is something that was agreed to, but did not turn out to be practical, possible, or possibly the best thing to do after in this particular type of research. Fortunately, a legal expert in South Africa wrote another follow-up article in which he argued that a sample may legally be removed or an autopsy conducted without an advance directive, without proxy consent, when there is a critical care patient who has died of COVID-19 and where the research is incredibly important in the public interest. So legally in South Africa, it is possible to do research of this nature with a complete waiver of consent based on necessity. And so it's incredibly important that research ethics committee members familiarize themselves with the laws of their country and understand what is possible and what is not possible in the context of a pandemic. Then I'm going to quickly touch on the Muri framework, which was developed by the World Health Organization. And for this type of research, where experimental medication is used outside of its normal indication. So for example, you will be familiar that during COVID, chloroquine was widely used at the start of the pandemic. And now if this particular medication was used, then it fell within the Muri framework of the World Health Organization. And so the World Health Organization has a number of stipulations that are required if this is to occur. And amongst them is the fact that the patient's informed consent is required. So many of you will know that chloroquine was widely used during the pandemic in hospitals around the world, often without patient consent. It was used during the peak of the pandemic when there was no treatment that was known to assist patients with COVID. And so doctors were trying everything they could. In other words, we moved right back to 18th century medicine, where trial and error became prominent during the pandemic. And as you can see, although this is a wonderful framework developed by the WHO, largely during the Ebola outbreak, this type of framework may not be possible in all settings, especially low and middle income settings, where hospitals are overrun, there are very few healthcare workers, and there is a crisis situation that does not make time for this level of consent. I'm sure you've heard about the study that occurred in Germany, a social science type study during the COVID, setting up COVID concerts and having 3 groups of people go in with varying levels of protection in terms of physical distancing, sanitizers, masks, etc. And they wanted to see whether these measures would work. Now imagine pre-COVID, which ethics committee would actually approve this? But this was approved and it did occur in Germany. And then of course we have all the COVID vaccine trials, and there are many in various phases of development. But there's also much discussion around human challenge studies. And although these are contentious, the WHO has put out criteria, and you will know one of the criteria is informed consent. And they say a rigorous informed consent. And then of course the bioethicists around the world are debating this, with Arthur Kaplan saying it is ethical to give someone a coronavirus, the virus intentionally, for the purposes of creating a vaccine rather quickly during an emergency. And of course, with Ruth Macklin arguing that because there is no accepted treatment for COVID, it is ethically not acceptable to do these studies. So where consent is concerned, it's taken many forms during this pandemic, ranging from simple observational research to in-depth interviews on Zoom or Teams or WhatsApp, to various types of clinical trials involving treatment, involving vaccines, all the way to the possibility of human challenge studies, which has never occurred for COVID, but has occurred for malaria, typhoid, dengue, and other diseases in the past. And so we can see that the world of research ethics has been turned on its head during this pandemic. And we all need to seriously look at our guidelines, start updating our guidelines, start thinking more clearly about how much community engagement we do. Because if we don't do enough community engagement, when the next pandemic comes, we're going to be faced with the very same ethics challenges where consent is concerned. Of course, we know that after the pandemic, there might be a whole range of lawsuits, which will include clinical issues as well as research issues. And we shall wait to see how these pan out. They will be interesting because we know that in many cases, measures have been put in place to ensure that whatever was done during the pandemic, as long as it was not grossly negligent, was done in the best interest of patients and the public. And so good arguments can be made for why individual interests could not be met during this pandemic. I want to thank you for your attention, and I'm going to stop now so that we can maybe take some questions.
thank you so much, Prof, for that enlightening presentation. It requires a lot of change, learning, and I'm sure the IRB members who are listening will go back to their institutions and try to implement some of those changes. So I would like to go into the question and answer session. One of the questions which was asked by Nicholas was a request for an example of biases that investigators might have, but are not ethical at all. But under pandemic conditions, it might be forgotten or thought to be ethical. Do you have any example of biases investigators might have, which might not be ethical at all?
Well, I would say that given human nature, it's always possible that there would be opportunistic people who might think that it's an opportunity to get research done that would otherwise not be approved, or to get research done that would sort of fall under the radar, not be noticed, or that would benefit from a different ethical framework that was being used. So yes, you know, these are possible, and I really don't have examples, because all the research I know about has been done with you know, the best intention of finding solutions to the pandemic. But I'm happy to hear examples from others who may be aware of this.
Okay, we open the floor for anyone who has an example where biases might be there but not ethical at all. Does anyone have any example of these biases? Please go ahead, Blessing. We'll go to the next question.
In the absence of any contribution, probably it's better we move to the next question. Yeah.
Okay, thank you. The second question was from Emmanuel, which was asking, to what extent do the IRBs or ethics committees globally agree to the paradigm shift which is being suggested, especially waiver of consent?
So I don't think people are globally agreeing to anything. I don't think there have been many fora in which this has occurred. But it certainly is the time to start, and this has happened very much on a country by country basis. So I would invite you to look at the literature and to read some of the research that has come out during COVID. There are studies published that do not mention there was ethics committee approval, because the laws of the country allowed for the research to occur without ethics committee approval. There are, in fact, I have a PhD student who is looking at this at the moment. There are other studies published where it's clearly stated that a waiver of consent was used because of the nature of the research, because it was in the public interest, etc. And so we as a research ethics community need to have these global discussions. But I think as emerged in the earlier part of the discussion today, Africa needs to look at these issues for itself, via the African Academy of Sciences, via the African CDC. And these guidelines and decisions need to come from within the continent, because for too long, we've taken guidelines developed by institutions in the global north, American institutions to a very large extent, and we've just used them in Africa. And I think that needs to stop. I think we need to start thinking about what is possible in our own contexts. To understand the issues around contacting family members in Africa, I think is so important. Also, there's often the use of the word next of kin, which is actually an inaccurate term to use, yet it falls into all the guidelines. Legally, who is next of kin? It's an old terminology developed, you know, in the UK many years ago, and it was related to property transfer. Now, when we look at research, we need to think about, instead of using next of kin, because that can be very contentious in certain settings in Africa. Who speaks for the family? Does it follow the same rules as we have in our law? Is it the wife? Because in some communities, the wife doesn't have the same bloodline as the husband. So she might be regarded as an outsider, but the law says the wife or the husband. The law refers to spouse or partner. So who's the adult child? Who is the spokesperson for that family? And that's very difficult. We often speak about religion. Whose religion? Which religions do we need to think about and consult? And even within one religion, you have conservatives and you have liberals. And there may be completely different schools of thought when we talk about religion. We often talk about samples, blood, and cultural issues and religious issues. What about data? Can we have those same conversations? So I think there's so much missing in our rules, in our laws, and our regulations, that we need to move away completely from Western liberal individualism and think about communal African philosophies that are important in Africa and make our own rules for that.
Thank you for that, direction of thinking about, next of kin. The other question from somebody who decided to remain anonymous is the definition of human subject include the word living? This means the deceased will not will not be considered a human subject. What do you think? What is your take on that one?
Yeah, I think that's important also to figure out, because many of the regulations are written for living patients. Now, and in research, they're called participants. The Americans call them subjects, which we don't really like. So I think it's important that firstly, we are clear that our regulations have rules and guidelines for living participants in research, but that we also have rules or guidelines for what happens when a patient is deceased, because legally a deceased patient has no rights in South Africa. Whether this is different in other parts of the world remains to be seen. And of course, who speaks for the deceased person is also important. So I think most of the guidelines are written for human participants who are alive, and very little provision is made in guidelines for what happens when people die.
Okay, thank you so much for that. We need to have a lot of change. We are going to have a lot of changes with COVID-19 in our guidance and regulation. The next question comes from Hamadou, and it is asking, how can informed consent be measured using non-conventional methods as experienced during COVID-19 pandemic?
So how do we measure consent in pre-pandemic times? Very few research ethics committees monitor the research that they approve. So measuring consent, I think sites try to follow the rules. They follow the guidelines when there is a monitoring visit by the funder or the sponsor. They have to present their consent documents, but nobody knows how the consent process actually occurred. Research ethics committees very rarely audit sites while a study is running to assess the consent process. And if a research ethics committee decides to conduct an audit after the time, there are many loopholes in the system if they have not understood the context in which the research actually occurred. How do you measure the consent? So generally, it's mostly paper-based to a large extent. One would have to really measure the consent process. One would have to go back to participants and do qualitative research in terms of how they experience the consent process. So we ran an influenza vaccine trial many years ago and did an assessment of consent after the time. And despite extremely thorough consent processes, we found that people did not understand certain aspects of the research or had recall bias. So patients just didn't remember, like they do in clinical medicine. Patients don't remember half the things they are told by healthcare providers. Likewise in research, participants also tend to forget important consent information. They have the forms, there's been a process, yet if we, in the absence of reconsenting people on an annual basis for important studies, and especially for long-term studies, in a year's time, people may have forgotten a large amount of the information that was imparted during the consent process. Measuring it during COVID, well, that's quite a challenge. If you think about the many constraints researchers faced during COVID, you know, healthcare workers were busy. Researchers coming in between everything in the chaos was a nuisance. They weren't allowed to take in their phones or clipboards, etc. So how do you measure it? Very difficult, which is why in some types of research, a waiver is required.
Okay, that really must have been a big challenge. The next question is from Emmanuel and is asking, is it ethically right to carry out vaccine trials for COVID-19 in African countries when the morbidity and mortality from COVID-19 is lower compared to the European population?
So I think that Africa is not one big homogeneous continent. I think we have to look at the different African countries and look at the impact of COVID in those countries. It may be the case that in some cases, for a number of reasons unknown to us, there's a lower incidence of COVID. In some countries, there's inadequate reporting, so the actual data we have doesn't match what is actually happening. But there are also parts of Africa that have got serious outbreaks. I can tell you that in Cape Town, we're now experiencing our second wave and our ICUs are already full. So in our context, a vaccine would be very important, and South Africa is involved in COVID vaccine studies.
Okay. The next question is from Azar Saleh in Egypt, and is asking whether a waiver of consent in pandemic studies cannot be considered as exploitation.
That's a very good question. Now, I made very specific remarks about when a waiver would be required. It certainly is not going to be required for all research that happens during COVID. There are going to be very specific studies that will require a waiver, and that waiver would have to be approved by a research ethics committee. So if we are thinking about a study scientifically, and if the committee is convinced that it has scientific value, that it has social value, that it is in the public interest, then why would it be exploiting anybody? So when we are ill, we all go rushing to the hospitals. Whether we have traditional healers or traditional doctors, everybody rushes to the hospitals. We accept Western medicine. We expect to be treated. Yet we have lots of issues around research. So we need to be very clear about what we expect from the healthcare system, where the information comes from to create the evidence to guide clinical care. And we need to be clear about how whether we're going to be selective about when we say this is exploitation and when we understand that it is for the public interest and to improve healthcare. So we need to be very clear about those aspects. Yes, I agree that there has been a history of exploitation in the context of research. And having studied the history of research ethics for my PhD, I know this only too well. And I, like you, would not like anybody to be exploited in the name of research anywhere in the world. But we need to be very clear about when we are allowing a waiver, and that there are very specific rules. Like I outlined the rules for deferred consent. there should be very specific rules for a waiver, and those need to be adhered to prevent exploitation.
Okay, thank you for clarifying that. The next question is from Abdul Jallo, and is asking whether during the COVID-19 pandemic, a lot of people volunteered or were forced to do a COVID-19 test for one reason or another, for any research, while the
Mary, I didn't hear all of your question.
Jallo is asking that so many people tested for COVID-19 for one reason or another during the pandemic. Is it ethical to use those samples for research where the participants did not consent to research?
Well, I would say that the research samples were given for diagnostic purposes in a clinical setting. If during, and as I said earlier, it depends on where the samples were stored. And in my opinion, if there are samples available and important research needs to be done to impact on the pandemic. In other words, I wouldn't allow for the samples to be used for any type of research. But if there are samples during a pandemic that could be used to generate new knowledge on the pandemic itself, whether there was consent or not, those samples should be used. And again, the argument is in the public interest.
Okay, maybe that one, if we have time, we could go back to it and hear what the audience has to say about it, because it's rather controversial. Then another question from Stephen Muhida from Kenya is asking, what is the main difference in a physician using chloroquine or any other untested drug to treat a critically ill patient who cannot give consent, and using an untested drug in a research trial for a patient who is critically ill who cannot give consent?
So Stephen wants to know the difference between using chloroquine in a pandemic and using, okay, so what happens is there's two issues to think about. In the pandemic, there was no other treatment available. So for COVID, we had no standard of care. In a clinical trial, there is usually standard of care, except if there was a clinical trial during COVID, then there was no standard of care except for all the package of prevention measures. This happened during HIV as well. You know, there was always a debate around the standard of care. So the difference is that it's big, and the context would fall under the Muri framework of the WHO that I discussed earlier, where you are using a drug that is registered, but not for the indication that is occurring during the pandemic. So it's registered, but chloroquine is widely used for malaria. So a large amount of information exists about the drug. It just doesn't exist for COVID. So using it in that context to treat people in an emergency with the hope of it working is different from putting that drug into a clinical trial in a non-COVID context when you don't really have any information. So many of the compounds that go into clinical trials are new drugs under development, where they have not been tested in any other disease. So that is one of the big differences between using chloroquine in COVID and using another investigational drug in the context of a clinical trial.
Okay, Julius is asking whether, is it Julius? Yes. How would you rate the success of the paradigm shift, which was adopted in this COVID-19 pandemic, against the success recorded in the 1976? Are there any data available or landmark successes recorded from the current paradigm shift so far?
I don't think the paradigm shift even occurred. So it's not measured, it's not recorded. It's for the ethics committees to start discussing with each other and thinking about this. What I said was a paradigm shift was necessary during the pandemic. It's my feeling that this didn't occur.
Okay, maybe that requires further discussion in another forum. From Ibrahim Sisi is asking, during the pandemic, there were lots of copied and paste kind of public intervention or regulations in many African countries, when in the reality, the pandemic doesn't affect Africans seriously as it did in Europe and the US. So these copy and paste interventional measures could have caused more harm than the virus itself. Is that ethical and sensible?
Yeah, copy and paste doesn't work in most situations. We've done too much of that. It's a bad habit that we need to lose. So I think context matters. We've written 2 articles, one in the Hastings Center and one in Developing World Bioethics, and I'd really like you to read those articles. Because it talks about developing an approach to COVID that is context specific and that works in Africa. So much differs in Africa compared to the rest of the world. There are at least 10 countries in Africa that have no ventilators whatsoever. There are many other countries that have a few ventilators and very few healthcare staff. So doctor-patient ratios differ widely throughout Africa. If we look at the triage guidelines that were developed in the USA and imported around the world, I mean, people just blindly use the critical care triage guidelines. SOFA scores that must be done in an ICU are not practical in many African settings. Doing a clinical frailty score also may not be possible and also may discriminate against the elderly and those with disabilities. There was so much copy and paste done that one became rather concerned during the pandemic. And I think this has been, as I said, it's been going on for a long time, and we need to develop context-specific guidelines, whether it is for clinical care or for research, because that is what is needed in Africa.
Okay, thank you for that. We really have had an interesting discussion, and we have a few questions to cover that we need to go through. Osama asks, what about volunteers' rights during participating in clinical trials for vaccines?
So a vaccine trial it depends what vaccine you refer to. If you're referring to the COVID vaccine, then participants volunteer for those vaccine trials. And that means everything all the rules you usually follow for any other clinical trial are applied to a regular COVID vaccine trial. The development of COVID vaccines was accelerated for good reason. But the conduct of the clinical trials followed all the rules, which is why you would have noticed that if a participant developed an adverse event, the trial was stopped. There was a DSMB, investigation. People had to follow ICH GCP. So the rights didn't change. People had rights. A similar situation exists if we think about human challenge studies. They are not going to be done without consent. In fact, the consent process, as you could see from the WHO guidelines, has to be extremely rigorous. So, including a test of understanding. So where COVID vaccines are concerned, and in South Africa, we have lots of experience with HIV vaccine trials. Now, in these scenarios, consent processes were extremely rigorous. People volunteered. A test of understanding was done, and if a participant did not understand the consent information at a fairly high level, that means scoring anything from 80%, 90%, those are the levels at which they were set. then that person was not enrolled. So I think in your, to respond to your question, there was no change in participant rights for vaccine trials.
Okay. I think another question from, where was I? Abdano Sama, lost this one. There was a question from maintenance, which was saying, oftentimes there's a lot of bureaucracy in carrying out research and some people get frustrated. So what happens if
Mary,
breakthrough result?
I couldn't hear the rest of your question.
The question is that there is a lot of bureaucracy for one to be able to carry out research. Can you hear me now?
I can, yes.
Yes, that there is a lot of bureaucracy in carrying out research and people get frustrated. But what if somebody carries out a research that gives a breakthrough result? I suppose without going through the right procedures.
Well, bureaucracy, that is something we also need to reconsider. I mean, during COVID, there were ethics committees have got a terrible reputation for delaying the conduct of research because they have always taken far too long to review protocols. What the pandemic taught us was that reviews could be done much more quicker and efficiently, using online webinars to do ethics committee meetings, etc. And processes were accelerated for good reason. So we know that in pre-pandemic times, there's a huge amount of bureaucracy. Try doing a study on research ethics committees, and then you will realize how much bureaucracy there is. For one, every research ethics committee wants to approve the same study in a particular country. Even though it's minimal risk research, it may involve interviews with research ethics committee members who are empowered to make a decision and who understand research very well. Yet you will find 10 ethics committees wanting to review that research. So what my feeling is that there's a lot of bureaucracy that needs to be cut, that we need to streamline our processes in terms of reviews. Reviews do need to be done thoroughly, especially in high-risk scientific studies and clinical trials. But we need to figure out how to differentiate risk in research and ensure that our response is proportional. So if we have a minimum risk study, then we need to treat it differently from a high-risk study and cut out the bureaucracy, make sure that our processes are a little bit more efficient and ensure that research gets done, especially when we know it's urgent research. There were some committees that took up to 4 weeks to approve research during COVID. And in that case, some of the researchers, they lost patients because the first wave had come and gone. So we have to think about responding appropriately. And many committees lack the courage to make difficult decisions when they need to be made. And in this way, they do block important research.
Thank you for that observation, and I hope the ethics committees are listening. So the other question is from Ibrima Sisi, who is asking, will it not be wise and scientifically justified to do the COVID-19 vaccine trial in countries and communities that show high susceptibility to the virus than those communities that have not shown predominantly shown predominantly asymptomatic signs? What was your expert opinion on this?
I think vaccines are going to be important and will be used all over the world. People from all countries travel. COVID vaccines may very well become a travel requirement the same way that yellow fever vaccination is a travel requirement, and other vaccines in different countries. So I don't think there's ever going to be the case where we can say one country needs a vaccine and other countries don't need it. I think the world needs a vaccine. And I think that nobody is safe unless everybody is safe. So we need to re-examine how we think about these things, and we need to think globally. And thinking that if a country has low risk, then it doesn't need a vaccine, may be short-sighted in the long term.
Okay, I don't know how you will fit this one into informed consent, because it is saying from Janko, saying that now that we are hearing that vaccines are available and a huge number of people are saying that they won't take the vaccine, what do you think is their reason for not wanting to take the vaccine?
So vaccine hesitancy is very well known around the world. I think what is going to happen in the first phase of vaccine rollout in all countries where there are limited resources is that we're going to have to choose those at high risk. And I've published an article in the Lancet Global Health a few weeks ago, in which I outline the approach in South Africa, where those people who would be at high risk would get the vaccine first. And of course, those who decline a vaccine will simply be excluded. And it actually suits the world now to have those people who decline, because there isn't enough vaccine to go around. In the long term, it's important that vaccine education occurs and that people fully understand the role of vaccines in infection prevention and in public health, and that people understand the concept of herd immunity. Because if enough people do not take the vaccine, then we cannot get the protection that we have in the case, for example, as we have with smallpox. When a disease is eradicated, we've achieved herd immunity. But when people decline vaccination, then that's a completely different matter, and it can be a threat to herd immunity. So a lot of community education and engagement is necessary to address that problem. But that's a topic for a whole nother webinar.
Okay, thank you for that question. We really don't have much time, but we still have a few questions. There's one from Thomas.
Sorry, Mary. Hi, sorry to interrupt you. Thank you very much. I think we are going to have to end, unfortunately. We've actually gone over time. Perhaps I could just quickly wrap up. So, Mary, thank you very much for chairing that session. And there was a lot of discussion. And Kemantri, thank you for a wonderful, wonderful presentation. And I think, as you said, there's things for a whole other webinar here. We could talk all day. It's fantastic. But unfortunately, we do have to finish for the day. So I'd like to just very quickly thank both our chairs. I'd like to thank all of our speakers today. Wonderful presentations. As we said, this is all being recorded. It will all go up on the hub, so you'll be able to look at it again. And we are collating all the questions. And in fact, some of these questions we may be able to pick up again in the overall discussion at the end of day 2 tomorrow. And please do look at the Pandora Knowledge Hub at the Ethics tab. We'll be able to post a lot of the links and things that Kemantri's mentioned in her talk and others have mentioned in their talks. And we've also got some discussion fora going on there. So please do have a look at that. I'm so sorry we have to end because I'd like to carry on as well, but sadly time's run away with us. Don't forget though, we've got day 2 tomorrow, same time, same place, 800 GMT. Tomorrow we have 2 sessions again. We've got biobanking in epidemics, and then we've got ethics review in epidemics. We may have a little wiggle around with the agenda because we may, 1 or 2 of our speakers may have to change, but those will be the 2 topics for tomorrow. So I'd just like again to thank everybody very much for a wonderful morning or afternoon today, and thanks a lot. And we look forward to seeing you all again at the same time tomorrow. Thank you very much, everyone. Bye for now.
Thank you.
Thank
Bye.
you. Bye.
Bye.
Bye-bye.